consultant diabetologist from Medina Diabetes Center, and also I am head of academic and training affair in King Fahd Hospital and diabetes leader in Medina Health Cluster. I would like to thank all of you to attend this and participate in this symposium, and also to thank the Future Vision for their invitation me to be present and speaker in this symposium. نبدأ بإذن الله about today our topic about insulin therapy, which is the continued for the previous lecture yesterday about the insulin therapy, and it is some of information available yesterday we discussed together, and some information which will be new for us. As we know, this is the Frederick Banting and Carlos those two who is discovered the insulin in 1922, and on the right side, this is the first child who tried the insulin. As we say, the first thing he is about to die, and after that he is improved a lot, and he regaining his weight and regaining his health also. So the question is, what is the indication for insulin use in type 2 diabetes? As we know, type 1 diabetes is mandatory and must to be treated by insulin. As there is no insulin secretion, there is insulin deficiency in type 1 diabetes. But what about the type 2 diabetes? Type 2 diabetes, usually it's caused by insulin resistant plus or minus insulin deficiency. So for that, the indication for use of insulin in type 2 diabetes should be addressed and assessed regularly in any patient with type 2 diabetes to check their need for insulin or not. About the indication, in any acute illness requiring the hospitalization, those patients with type 2 diabetes should be treated by insulin therapy. In a perioperative and an intensive care unit setting, all those population in critical care setting should be treated with insulin therapy. In high-dose glucocorticoid therapy, as we know, those patients leading to more insulin resistant, and those patients need to be taken treated by insulin therapy. Inability to treat or contraindication to oral anti-glycemic agent. Those patients who are not controlling on oral hypoglycemic agent, the patient tried this oral hypoglycemic agent, but unfortunately failed to improve or failed to reach their target. So after that, please don't delay the initiation of insulin therapy in those patients to reach the early control of the diabetes. And in any new diagnosed type 2 diabetes with significantly elevated blood glucose level, especially if the patient present with severe symptoms of catabolic symptoms, which is polyuria, polydipsia, or weight loss, and if the patient presented with DKA or HHS. Mostly those patients need to be treated from the early stage with insulin therapy, even though they are in type 2 diabetes. Also, in that pregnant lady, if the pregnancy become, it's important to treat those patients with insulin therapy. Although there is some oral hypoglycemic agent, it's approved to use in patients during the pregnancy. But unfortunately, most of the pregnant who are type 2 diabetes, when they are when they are becoming pregnant, they need more intensive insulin therapy, and they should be treated by insulin therapy. And at any time of diabetes management, if the patient is agreed to use insulin, even though the patient is a well-controlled diabetes, but he is or she has agreed on use of insulin instead of oral hypoglycemic agent, we should offer this medication for them. And in any time, if we think there is uncontrolling, we cannot controlling the diabetes with oral hypoglycemic agent, we should treat them with insulin therapy. So what is the barrier becoming in the way of the starting insulin therapy in patients with type 2 diabetes? Usually the initiation of type 2 diabetes is delayed in most of the patients with type 2. As we discussed yesterday about the clinical inertia in starting insulin. So the question, what is the barrier? The barrier is either patient concern, when if the patient fearing of shot or injection, the patient think the diabetes become more serious and he cannot controlling his diabetes, and the complication will be started soon after after he is treated with insulin therapy. The patient sometimes fear of hypoglycemia. I think if he take the insulin, he will be a good candidate, or he will be complicated by hypoglycemia. And also as a complication, most of the patients, when you try to start them on insulin therapy, they directly think about the complication. He know that person when he started the insulin, he already after at times he tried to dialysis or he had an amputation. What's that mean? That means the initiation of insulin therapy is delayed till the complication starts. The patient is a poorly controlled diabetes, but we not initiate insulin till he had a complicated later stage of complication. So please don't blame the patient when they are concerned about this misconception. But instead of that, you can give him the direct information. You can give him a correct information about the importance of using insulin if they need in management of diabetes. And sometimes there is inconvenient to use that. How can we make the patient satisfied using insulin therapy as treatment of diabetes? By knowing the patient or by educating the patient about the nature history, the natural history of diabetes, especially type 2, which is the progressive in nature. And those patients should be educated. Diabetes type 2 is progressive in nature, and the beta cell functioning was declining as the time progress. Sometimes patient may sense of failure. I try oral for a long time, but I cannot reaching my control, so my diabetes is difficult to control. It is impossible. The insulin therapy sometimes is the mainstay of management of type 2 diabetes, especially in those patients with long-standing diabetes with poorly control. In a lot of trial, they found that most type 2 diabetes, after 6 years from the diagnosis, they in need for insulin therapy to control their blood sugar. On the other hand, we have a doctor concern or a healthcare worker concern. Usually they concern about the hypoglycemia. What if I inject or if I advise the patient to take insulin therapy? What about the hypoglycemia? The patient may develop the hypoglycemia. And they think about the complexity of starting and adjusting medication. How can we start the insulin? How can we adjust? How can we follow this patient? Does the patient develop anything, any complication? How can we fearing or how can I interfere with that? Also, they concern about the weight gain. What if this patient started an insulin as a side effect? The weight gain is, as we know, it is one of the main side effect of the insulin therapy. And sometimes we fear from patient anger or confrontation. What if I told my patient he is in need for insulin now? He may be angry for me. He may be becoming in confrontation with me. Why that? As we said, it is mostly related when the patient is not aware about the progressive nature of his diabetes. And also sometimes we have other concern. What about the resource? What about other specialty dealing with us? What about the healthcare? About the educator, the dietitian? What the role of the pharmacy? Who is the one educates the patient about how to inject? Who is the one is following the patient home reading? Who is the one taking care of this patient? All these concerns should be coming in mind sometimes when we starting insulin therapy for those patients. This barrier will affect the patient outcome by significantly delay in commencing insulin. They lead to poor compliance to the therapy, poor adherence to the injection, and poor adherence to titration of the dose, failure to meet the glycemic target, and also result in significant risk of increasing micro and macrovascular complication. All these barrier should be addressed, and as we know, will affect the controlling of the diabetes and increasing the probability of developing the complication of diabetes. So how can we address all these complications or all these barriers? How can we resolve? How can we overcome this barrier? It's usually by education, education, and education. Education for us as a healthcare worker to how overcome the clinical inertia and educate us about how we can start the insulin and follow up the patient with diabetes and start those patients with insulin initiation and titration. Also, education for other healthcare workers, like educator. How can they follow the home reading? How can they adjust the dose of the insulin? And also education for the family and for the patient and family, and also for any caregiver for those patients. How can they titrate their insulin? How can they inject their insulin at home? What is the importance of home reading? And how can they follow these home reading? What's the type of insulin we have? We have a human insulin and insulin analog. In human insulin, we have basal insulin, prandial insulin, and premixed insulin. Basal insulin, which is the regular insulin or Actravit, about about basal insulin, which is the NPH, and the prandial insulin, which is the regular insulin or Actravit insulin. In the premixed insulin, also we have the Mixtard, which is the old generation of insulin, which is the human insulin, and usually these medication will be need to be drawn by a needle. On the other hand, we have insulin analog. In insulin analog, which is we have the basal insulin, which is the glargine, Detemir, and degludec. And also in prandial insulin, we have lispro, aspart, and glulisine. And even though we have the premixed insulin, which is in the form of premixed from a prandial insulin plus protominated prandial insulin, which is leading to an intermediate action of this medication or of this insulin, leading to premixed insulin. In premixed insulin, we have lispro, aspart, and degludec plus aspart. All these are premixed insulin analog. It is important to know the pharmacokinetic of the available insulin. Why it is important to, when we educate our patient, when they take their insulin, when they expect the outcome, or when we expect the onset of action for this insulin. Also, we should know about the peak of this insulin therapy. For example, when we start with basal insulin, in basal insulin, we have NPH, which is the human insulin, and it usually start to action in 2 to 4 hours, and its peak around 4 to 8 hours, but its duration is less than 16 hours. So usually NPH given by 2 times per day. This type of insulin has a greater risk of nocturnal hypoglycemia compared to insulin analog. The other basal, we have the insulin analog, which is the glargine, Detemir, and degludec. These type of insulin usually start their action around 1 to 2 hours, and there is no peak. Usually, this basal insulin is a peakless, and its duration is about 24 hours, and it is increasing or decreasing a little bit in some of these medication. Those type of basal insulin, there were no or less nocturnal hypoglycemia as compared to NPH. On the other hand, we have basal prandial, which is the mixed insulin, which is the mixed effect, but it is a concentrated regular insulin, which is the regular U500. These type of insulin actually not available routinely in the markets, but usually started or given for those patients with a high insulin resistant. And it is some precautions with this medication for the dose adjustment and for the amount of the insulin injected. On the other hand, we have the prandial insulin. In a prandial insulin, also we have regular insulin, which is the human insulin. Usually start their onset within half an hour, and it's their half peak around 2 to 3 hours, and its duration around 8 hours. So mostly in regular insulin given 2 times, but sometimes they can given in 3 times in special population. Mostly, these regular insulin should be injected half an hour before a meal and injected with or after a meal could increase the risk of hypoglycemia since there is a huge peak after 2 and 3 hours. Other types of prandial insulin, we have the insulin analog, which is the aspart, glulisine, lispro, or inhaled insulin. These insulin take action within half an hour and usually peak around 2 hours after injection. Usually the duration of around 3 to 5 hours, and those prandial insulin can be administered within 15 minutes before a meal. And as compared to regular prandial insulin, there is less risk of postprandial hyperglycemia or hypoglycemia. We have a different concentration of insulin therapy. We have U100, U200, U300, and U500. What we mean by these U100, 200, 300? This means concentration of insulin. This means how many units per ml, how many units of insulin per ml. For example, in U100, which is the most commonly insulin available in the market. That means there is 100 international unit of insulin per ml in the bin. And usually these bin with U100, there are a 3 ml per bin. That means in the total units per bin is around 300 ml. The other mostly common available in our market, which is the U300. In U300, that means a 300 international unit per ml. And those bin usually have 1.5 ml per bin. So that means there are a 450 international unit per bin. Bins completely eliminate the need for converting the dose based on the volume of insulin injected. Since the bin is already have the scale, the number of the unit need to be injected. Insulin bin significantly reduce the risk of dosing error and hypoglycemia event. As we say, since there is a scale, there is a number, and the patient follow the number, and after that start to inject themselves. Dosing error with U500 insulin vial are common and dangerous, but can be avoided with the newly available bin. In U500, which is the human insulin, and usually these medication in the vial, not in the bin. So by calculate those type of insulin need to be calculated and shifted to the required unit, since it is 5-fold higher relative to the U100 insulin. Also, we have a fixed ratio injectable combination agent available in our market for type 2 diabetes, which is usually a combination of insulin therapy plus GLP-1. In Xeltophy, we have the liraglutide plus degludec, and also we have the Cerequa, which is the lixinatide plus glargine. How can we treat our patient? Usually, we recommend you to follow all these aspects or a decision cycle for any patient when treating with diabetes. Usually, we put the patient at the center of our care, and our goal for caring with patients with diabetes is to prevent the complication and optimize the quality of life for those patients with diabetes. First of all, we need to assess the patient characteristics by his lifestyle, his comorbidity, his clinical characteristics, his age, hemoglobin A1C, weight, and other things. What about the specific factor that impact choice of treatment? Does the patient have any complication, any risk of hypoglycemia? What is his weight? Does the patient can follow the complexity of regimen? who is the one caregiver for him, availability of this medication, and the cost of the medication. On the other hand, we need to make a shared decision with our patient about the availability of medication, which is the medication is the best for this patient, and try to empower our patient about controlling our recommendation and actively participation in controlling their diabetes. Also, after that, we should be in an agree of management plan, which should be a specific goal done to the patient, what their target for A1C, what our target for fasting blood sugar, and what our target for hemoglobin A1 for postprandial blood glucose, and also implement the management plan. After we set the goals, our goals for controlling the diabetes, we should implement the management plan. After that, we need to follow this management plan and take in consideration other factors, non-hyperglycemic control, which is the weight and lipid profile, and the blood pressure should be addressed and should be controlled in any patient with diabetes. After that, those patients need to be regularly follow their plan and reassess our decision cycle, our management plan. Is it acceptable for this patient? Does the patient follow all these plan or not? Does this management plan need to be changed or not? So when we starting insulin therapy in patients with diabetes, we should set a target or a goal for glycemic control. It is important for any patient to set the goal. The patient without the goal, he not know till when he controlling his diabetes. What's important for controlling the diabetes? Usually the patient came and asked, what is my hemoglobin A1C? He's not aware what the number you give him, he's not aware about that. But we should set the target, set the goal for our patient. Your hemoglobin A1C should be less than 7, for example. That means those patients now try to convince or try to reach this target. But if we don't let our patient know about our target, he will not reaching the target. Then use an algorithm to advance therapy. Determine appropriate insulin regimen, calculate the starting titration insulin dose, and educate the patient and the family. All these 5 steps should be addressed in any patient when we try to initiate any patient with diabetes. We will go through it quickly, and yesterday we discussed most of this. About the goal of A1C should be less than 7 for most adult non-pregnant, and also the preprandial capillary, it is from 80 to 130. In peak postprandial, we have less than 30 milligram per deciliter. It is important to agree with this patient with our patient about these goals and these target to reach, since the patient who is the one responsible to make the controlling of his diabetes to reach these targets. These targets should be individualized according to the patient risk and according to the patient characteristics. Usually we have some characteristics need to be more concentrated or more strictly controlled, and some characteristics need to be relaxation in controlling of diabetes. Risk associated with hypoglycemia, disease duration, life expectancy, importance, comorbidity, cardiovascular complication, patient preference, and resource and support to the patient. All this as a factor, depend on it, we can individualize the glycemic control. For example, what about the diabetes duration? What's that mean? Diabetes duration of the patient is newly diagnosed diabetes, we should restrict their controlling of blood sugar. But if the patient is in long-standing diabetes, we can add some relaxation for their blood sugar. What about the life expectancy? If the patient life expectancy is high or long, we can strictly control their blood sugar to prevent the late complication for those patients. But if the patient had a short life expectancy, we can make some relaxation in controlling of blood sugar. What I mean by life expectancy, if let's say this patient coming to you, we have 2 patients. One patient is coming to you in his 30s. So we need to strict control his blood sugar. But if the patient comes to you in his 80s or 90s, those patients, we should make some relaxation for them to prevent the complication of hypoglycemia, and it is not aware about the risk of complication for those patients. Then use algorithm. Usually, without guidance, we cannot control the diabetes, and we will prefer to use any guideline for diabetes control. We have a different and multiple international diabetes guideline. We have the ADA, Canadian, European, and Australian. Also, we have the NICE and the ADF. You can choose any one of these guidelines and follow to implement in your patient, depend on your satisfaction and depend on your patient culture and acceptance. Usually, we prefer to use the ADA, American Diabetes Association, or an agreement between ADA and the European Society. But you can use any one of them. It is valid, and if you think it is applicable to your patient. This is an example for the ADA guideline and the American Association of Clinical Endocrinology. After we use the algorithm, or if we use the guidance for insulin management of patients with diabetes, we should determine the appropriate insulin regimen, which is the appropriate regimen for those patients. We need to balance between time-effective and stable glycemic control with low risk of hypoglycemia. As we know, in management of diabetes, we are trying to control hyperglycemia, but also we need to prevent the developing hypoglycemia in those patients with diabetes. In insulin regimen, we have either basal or premixed insulin or basal plus. Those types or those category for insulin should be individualized according to the patient characteristics and the glycemic factor. And we should address in any patient no one size fit for all. So we need in any patient, we think about all these factors to choose which one is the best for this patient. And after we choose one, we can discuss with the patient what is the importance for that and how can patient reaching the control of this patient and why we prefer these over the other. For example, in glycemic factor, if the patient had elevated fasting blood sugar, we can use any one. But if the patient had only elevated postprandial glucose, we prefer premixed insulin or basal bolus instead of basal alone. If the hemoglobin A1C is more than 10, we need more intensive insulin therapy in the form of premixed insulin or basal bolus or basal plus GLP-1 instead of basal insulin analog. Patient factor, if the patient prefer to fewest injection, we can use the basal or premixed insulin rather than basal bolus. If the patient has variable meal pattern, it's preferred to use the basal bolus instead of the fixed ratio premixed insulin or basal insulin. And like that for all other factors, which is the limited capacity, cognitive visual function, dexterity. If the postprandial control required, we mainly concentrated about the premixed and basal bolus. If the patient is unwilling to do home reading, those patients can be offered for them basal or premixed insulin. Instead, we should educate those patients the importance of that home reading. If the patient don't have a family support or a healthcare resource, we can use for them the basal insulin or premixed insulin instead of basal bolus. But if you chose any one of them, it is true. And there is no wrong choice, but we prefer one over the other depending on the patient characteristics and the glycemic factors. This is also an example of ADA guideline about initiating of insulin therapy. So in any patient with type 2 diabetes, we can give the patient a chance for controlling their diabetes by oral hypoglycemic agent. In oral hypoglycemic agent, we should advise our patient and knowing the characteristics of the patient. If the patient had ischemic heart disease, chronic heart failure, or chronic kidney disease, those patients preferred to be treated with SGLT2 inhibitor or GLP-1 from the start, even though nowadays the guideline, we can use this medication even before the metformin. And if the patient had a risk of hypoglycemia, we can use another medication with less risk for hypoglycemia. And also we need to reduce the weight gain, and if the cost is the issue, we try to give the patient or offer a medication with less cost. After oral hypoglycemic agent, we proceed to the injectable treatment for patients with diabetes. We can start with GLP-1 in most patients prior to insulin, but if the patient had any catabolic symptoms or his hemoglobin A1C poorly controlled, even they started with GLP-1, we can start the patient on basal insulin. And start insulinization of the patient with diabetes, we have a three approach: either basal insulin in a stepwise approach over the oral hypoglycemic agent, or we can directly shift the patient to premixed insulin or shift them directly to multiple daily dose injection, depending on the patient characteristics and the requirement of controlling the blood sugar. In the basal insulin, we usually start the basal insulin by a rough number of 10 international units or 0.1 to 0.2 international unit per kilogram per day. And after that, we need to educate about our patient about the titration of the basal insulin depending on the fasting blood glucose. If the patient not reaching the target for the fasting blood glucose, he can increase his basal insulin by 2 units every 3 days, or increasing it by 10 to 15% of the insulin. But if the patient had hypoglycemia, we need to reduce the dose of basal insulin by 4 units or 10 to 20% from the insulin. Those patients started on basal insulin, we can continue all the other medication or the other anti-hypertensive medication, anti-hyperglycemic medication. Basal insulin can be given at any time of the day, but we prefer to use a fixed time to take insulin every day. It is not related to the bedtime. It is not related to the meal. Just we need to fix time for taking basal insulin. What if the patient not reaching the control of blood sugar? If the patient is not reaching the control of blood sugar with basal insulin, we have to proceed. We have to make a more intensive insulin therapy, either in the form adding of prandial insulin to the main meal or the meal with a highest glucose excursion, then increase to the other meal, and finally by the third meal with a complete or a full basal bolus injection. Or we can shift the patient directly to basal bolus insulin. In the basal bolus insulin, we can start, as we say, the prandial insulin by 4 units or a 10% of basal dose, or we can, and also if we need to shift directly all the patient to the basal bolus insulin, we should stop all the secretagogue and most of the other medication, oral medication, should be stopped when we're shifting to the basal bolus. Unless we can continue in metformin, SGLT2 inhibitors, and GLP-1. These 3 groups, we can continue in the basal bolus insulin and take in consideration the risk of hypoglycemia. We need to check their home reading regularly. Usually, the basal bolus insulin given as a 0.3 to 0.5 unit per kilogram. Those doses should be divided into 2/3 taken at divided to 50-50, and 50% of the total daily dose should be given as basal insulin, and 50% of the total daily dose should be divided to 3 times and given with prandial insulin in pre-meal injection. Titration of prandial insulin also, it is important for any patient with diabetes. We can check both preprandial and postprandial hyperglycemia. And if we have hyperglycemia, we need to increase the dose by 2 units and 2 unit or at 10 to 15% every 3 days. Also for the hypoglycemia, we need to reduce the dose by 10 to 20%. What about the premixed insulin? The premixed insulin should be given into 2 doses and sometimes can be given in 3 times per day. Those doses should be given in pre-breakfast and pre-dinner. If the patient is shifted from basal insulin or is start just a naive patient on insulin, we can start him on 0.3 international unit per kilogram or start him roughly by 10 to 12 international unit of premixed insulin. But if the patient is already in multiple daily dose injection or basal bolus and those patients need to be shifted to premixed insulin, those patients need to be shifted directly by 1:1. For example, that patient is a total daily dose in basal bolus is 60, so we will shift that 60 as it's the same to premixed insulin, and after that we divided these doses to have the dose in the morning and half the dose in the evening, or 2/3 of the dose in with pre-breakfast and 1/3 pre the dinner. Also, it is important to know about the titration. This is one algorithm for premixed insulin adjustment in any patient with diabetes. For example, if the patient presents to you with less than 80 milligram per deciliter, we can reduce the dose by 2 units. If the patient from 80 to 100, we can keep it the same. But if the patient approaching 140, we can increase the dose by 2 units. If the patient is more than 180 milligram per deciliter, we can increase the dose of premixed insulin by 6 international units. So after we know all these type of insulin, the type of available insulin in the market, how can we administer these insulin? The most commonly prescribed or the most commonly mode of delivery of insulin, which is the subcutaneous route. Usually it is a vial and syringe or insulin bin, which is the commonly nowadays mostly in insulin bin. Also, we have the insulin pump. All these are a mode of insulin injection for those patients. So we have bin, we have needles, we have the insulin pump. In transdermal, we have some modality of or some mode of delivery for delivering insulin to the patient by a transdermal. Also, we have oral or buccal insulin, and we have nasal insulin. But all these types of insulin still need to be approved and need to be discussed and need to be researched more and more and more to make the safety of this medication and the efficacy in controlling patients with diabetes. Also, we have the inhaled insulin, which is nowadays is approved as Afrezza, but this inhaled insulin have a lot of complication, so it's not prescribed for any patient with any respiratory problem and need to be checked for spirometry before starting using these medication. And also we have intraperitoneal and intraportal injection of the insulin. All these are modality of insulin in management patient with diabetes. But we concentrated mainly about the subcutaneous route, which is the most commonly used in patient with diabetes. This is an example. This is the needle, the previous needle, and usually nowadays is used for the human insulin. This is the bin, the currently available bin we have, and also this is the insulin pump. So what is the advantage and disadvantage of delivery method? As we say, we have vial and syringe. This is the advantage of that. It's less cost and less expensive as compared to pen. But the disadvantage is pain increasing with those patients, and also there is a fearing of the needle, and also accurate. This is accurate versus than pen, since you are the one who take the insulin or who extract the insulin. What about the other type of insulin delivery method, which is the pen device? And this is convenient and less pain as compared to the vial and syringe. It is more expensive and cannot mix with two insulin. This is one of the important, as we know, the pen is ready for this type of insulin, and we cannot mix it with the other type of insulin. And there is no superiority of pen devices versus syringe for glycemic control. This is the benefit for just for satisfaction and for easy accessibility and easy to use this medication. But about the glycemic control, there is no difference between those type of insulin delivery method. Also, we have the other for the insulin pump, which is the continuous delivery of insulin, which leading to better glycemic control, and it's around decreasing when they try to make the difference between the basal to the when they make the difference between the pen device or continuous delivery, which is the insulin pump, they found that the difference is around 0.3 unit, 0.3% reduction more in patient using the insulin pump as compared to other modality of insulin delivery. The disadvantage of this medication is the cost and risk of decay if the pump fail or kinking or the tube is kinking. And these patient and those patients on insulin pump need to be more aware about manipulation and tuning with those patients and to handling this machine to prevent the complication and of the complication of diabetes and also to the complication of the machine. And also other we have intraperitoneal, inhaled, oral, buccal, and nasal types of insulin delivery, which is available nowadays, some of them, and some of them is under research, but it's still not approved to use for in population-based. So about the subcutaneous insulin injection technique, we need to ensure our patient and caregiver receive adequate education and understanding the correct insulin injection technique to optimize the glucose control and safety. It is important at any time if the patient is poor to come to use when he is in insulin therapy with poorly control to ask them about how can they use their insulin, who is the one taking, who is the one inject the insulin for him. As we saw from our practice, we have a lot of patients take the insulin wrongly and take either in the wrong place or take it in a wrong way or by not changing the needle, for example. We have a lot of misconception about the injection technique for diabetes, for insulin therapy. And also educate the patient about inject appropriate area and inject site rotation to avoid lipohypertrophy. It is important to rotate the injection site. Appropriate care of injection site to avoid infection, avoidance of intramuscular and insulin delivery, and use short needle. For example, a 4 millimeter pen needle is more effective and is more tolerated than a long needle. This is the main injection site, which is in the abdomen, in the lateral side of the thigh and the arms. And for those in buttocks, especially for the infant and the child, we can use buttocks for them. Okay, we have one video. We can share it with you.
تتشوه تتفرج كثر ما استخدم قلم دائما يسكر
ما تشوف شيء واضح انك ما كنت تستخدم قلم الانسولين بطريقه صحيحه.
طيب
واللي حصل بسبب انك تحقن الانسولين في نفس المكان كله. لكن راح اعيد لك شرح الخطوات الصحيحه. قبل كل شيء لازم تتاكد من تاريخ صلاحيه الانسولين، وضروري تتاكد ان الكميه اللي في العبوه كافيه للجرعه. ولما يكون الانسولين من النوع المخلوط خلي القلم بشكل عمودي في راحه.
الله يعطيكم العافية، تأكدوا لي بس الصوت واضح عندكم والفيديو واضح. Okay, it's good. We continue it.
اليدين وتدورها بلطف وتحركه من اليمين لليسار لحد ما يختلط تمام. تاخذ الإبرة الجديدة وتركبها على القلم، تلفها بهالطريقة لحد ما تمسك، ثم تشيل الغطاء. تخلي اتجاه الإبرة للأعلى وتعبي وحدتين من الأنسولين، ثم تفرغها من الهواء تماما حتى يخرج الأنسولين من الإبرة. وبعدها تحدد جرعة الأنسولين حسب وصفة الطبخ، وتحدد مكان الحقن، واللي مهم تغيره بانتظام. يجب الابتعاد عن الحقن في أي منطقة من الجلد تحتوي على جروح أو كدمات أو حتى حساسية أو طفح جلد. أماكن الحقن على البطن تبعد عن السرة بمقدار أصبعين من جميع الاتجاهات. وعلى الذراعين يكون الحقن في المنطقة الخارجية الخلفية للذراعين مع ترك مسافة إصبع إلى 3 أصابع تحت الكتف ومثلها فوق المرفق. على الفخذين الجهة الجانبية الخارجية ترك مسافة إصبعين إلى 3 من أعلى وأسفل الفخذ. أعلى الردفين يجب تغيير مكان الحقن في كل مرة بانتظام مع ترك إصبع بين أماكن الحقن في المنطقة نفسها، ويتم الرجوع للحقن بنفس المنطقة بعد 24. أثناء الحقن تحدد مكان الحقن، تمسح مكان الحقن مسحة طبية وتخليه يجي. تقرص الجلد بهذه الطريقة، نوجه الإبرة بزاوية 90 درجة وندخلها في الجلد بحركة سريعة. تترك قرص الجلد ثم تضغط بهذه الطريقة على القلم بالإصبع الإبهام إلى أن تخلص الجرعة، ونخليها لمدة 10 ثواني عشان ما يطلع الأنسولين برا. تسحب الإبرة بنفس الطريقة وتزيلها من القلم. الضغط على موقع الحقن لمدة 5 إلى 10 ثواني، وبعدها نتخلص من الإبرة في وضعها في حاوي بلاستيكية مخصصة مع غلقها بإحكام. ويتم تخزين عبوات الأنسولين في الثلاجة على الباب من الجهة الوسطى. واحرص على عدم فتح أكثر من عبوة في نفس الوقت، ولا تعرضها لدرجات حرارة عالية، واحفظها درجة حرارة الغرفة. ويجب التأكد من جودة الأنسولين في كل مرة بالنظر إليها عن قرب. ولا ننسى بأن الأنسولين يفقد فعاليته بعد 30 يوم من فتح العلبة. وبالأخير لا تنسى تغير مكان الحقن بانتظام وما تشوف.
طيب الله يعطيكم العافية. بعد ما شفنا هذا الفيديو حيكون لنا تعليقات على بعض الأشياء. في البداية ودي أسألكم سؤال. حصلت بعض الأخطاء في هذا الفيديو، مين يقدر يحدد لي الأخطاء اللي طلعت من هذا الفيديو؟ في أكثر من حاجة كانت فيها أخطاء وما نفضلها كأطباء متخصصين في معالجة السكر، دائما ننصح بعدم استخدامها. فودنا نتناقش فيها. مين اللي يعطيني أي فكرة، أي معلومة عن معلومة صدرت في هذا الفيديو وذكرت بشكل خطأ؟ طيب الأخ حسين
وأيمن وجاكلين. Yes, this is the main thing. واحدة من الأخطاء اللي حصلت إنه الضغط على مكان الحقن بعد الحقن. ما نضغط نهائيا إذا إحنا تركنا الأنسولين حتى ياخذ وقته كفايته وانتظرنا 10 ثواني قبل قبل نشيل الانسولين، قبل نشيل القلم، فما يحتاج نضغط عليه نهائيا، ولا نفضل ان الضغط على مكان الحقن. هذا واحد. النقطة الثانية من ضمن الاشياء اللي جات حفظ الانسولين في باب الثلاجة، الانسولين اللي ما انفتح ينحفظ في باب الثلاجة، اوكي صحيح ما في اي مشكلة، اما الانسولين اللي يكون انفتح واستخدمناه ينحفظ في درجة حرارة الغرفة، في درجة حرارة الغرفة بشرط انه ما يتعرض لأشعة الشمس وما تزيد درجة الحرارة عن 30 درجة. فترة تخزين الانسولين بعد فتحه هل صحيح 30 يوم؟ نعم. اي قلم انسولين بعد فتحه ب 30 يوم المفترض نرميه، حتى لو باقي فيه النص، باقي فيه كثير قليل، نرميه لانه يفقد فعاليته بعد 30 الى 28 يوم. القلم اللي ينفتح يحفظ في درجة حرارة الغرفة، في درجة حرارة الغرفة أكرر، بشرط أنه ما يتعرض لأشعة الشمس وما يتعرض لدرجة حرارة فوق 28 درجة. طيب هذا واحد من الأخطاء اللي قلنا أنه الضغط على مكان الحقن. النقطة الثانية اللي هو المسح بالمسحة الطبية. المسحة الطبية ما نفضل المسح فيها نهائيا، أنه يغسل قبل الانسولين، قبل ياخذ الانسولين ينظف المكان بمويه عادي اذا كان المكان ما هو نظيف، اما انه يستخدم المسحه الطبيه فما نفضله نهائيا، لانه المسحه الطبيه حتسبب معنا زي الكراكات وتؤدي الى زياده الالم في مكان الحقن. طيب نرجع الآن نكمل العرض تبعنا. فقلنا أهمية أن لما بعد استخدام الأنسولين أو ننصح البيشنت باستخدام الأنسولين it is important to self monitoring of blood glucose. لابد أن يكون مريض السكر إنه aware to how we control their blood sugar, how can they do the home reading, and how they can change the dose of the insulin depending on the home reading, and how can to deal with this reading, not just writing the number. He should know to how to deal with this number, how if they need to increase or decrease or need to titration of the insulin, depending on the education given to those patients. It is important to check blood sugar prior to meal and snacks, occasionally post meal if the patient had postprandial hyperglycemia, at bedtime, prior to exercise, and when they suspect low blood glucose, and after treating low blood glucose until they are in normoglycemic, and prior to performing a critical task such as driving or swimming. So in conclusion of our talk, many patients with type 2 diabetes eventually require and benefit from insulin therapy. The progressive nature of type 2 diabetes should be regularly and objectively explained to patient and the provider, should avoid using insulin as a threat or describing it as a sign of failure, and rather than utility and importance of insulin to maintain glycemic control. Once progression of the disease overcome the effect of oral agent should be emphasized. So it is important to educate our patient about the progressive nature of the type 2 diabetes. Educating and involving patient in insulin management is beneficial, not let our patient just to write their reading, but they need to write their reading and take action on that to improving their blood sugar. Instruct the patient on self-titration and comprehensive education regarding the self-monitoring of blood glucose, diet, and avoidance and appropriate treatment of hypoglycemia are critically important in any patient using insulin. Thank you for all. الله يعطيكم العافية جميعا. Now the time for discussion, if you have any question or comment. There is one question in Q&A from Amira. Dr. Why don't we use alcohol swab? Alcohol swab, it's causing a cracking for the skin, and it is becoming more painful for this patient. This is one. The second, it's had an interference with the medication, with the insulin. And if the patient use alcohol swab, those patients need to be wait till the alcohol swab be dry, after alcohol swab be dry. For that, it's causing the dryness and prevent the interaction with insulin. For that, we not recommend to use the alcohol swab before starting or before injection the insulin. Other question, temperature to keep insulin in room temperature, is it 25 or 30? And it is a 25 to 28. It's not more than a 28 for the keeping in room temperature. But it's if more than 30, if it is not open, also it should be destroyed for both. And if the patient taking the insulin, even he is open his insulin or not open his insulin, if he reaching the temperature of more than 30, they should be destroy this insulin. If the patient is open his insulin, he should be kept in 24 to 25, which is the room temperature. When the change from the oral tablet to the insulin after the failure to oral hypoglycemic agent, or when they are in need for insulin therapy. Failure, what we mean if the patient we reach 3 oral medication without reaching the target. And also it is important, please, not to delay the initiation of insulin. If the patient come to you without controlling his blood sugar, you can intensify the therapy, start by oral, and later on you can increase to insulin therapy. Thank you. I need the schedule for blood sugar monitoring. Okay, sure. Actually, the blood sugar monitoring, the schedule for that, we have a different guideline. We have a different society to make the monitoring of blood sugar, and you can use any one of them to controlling blood sugar to not to make one a specific one schedule. In BHCC, not clear and not complete information. What do you mean by BHCC? Primary Healthcare Center, what is it? Not clear and not complete information. I need more explanation for this question, please. After how many oral hypoglycemic agents should we shift to insulin? As we said, we can shift insulin. Insulin we can give into the patient at any visit. And we can start in insulin therapy from the first visit without oral hypoglycemic agent. But if we use the approach, stepwise approach, we can use insulin after 3 oral medication. Sign or indication to discard insulin bin. To discard insulin bin, if the duration after opening the bin is more than 28 to 30 days, if the insulin exposed to direct sunlight, if the insulin in the more than 30 degree from the temperature, and this is the main thing, or if there is a deposition or any change in the homogeneity of the insulin. This indication should be discard the insulin directly. Thank you for all. Can we have the recording for this presentation? Actually, I let this answer to the future vision if they have that or not. In home monitoring of blood sugar, which glucometer device do you recommend, since some give error reading? Actually, all the glucometer devices here in Saudi Arabia before they launching, or before they permit to buying and purchasing from the market, they take the approval from the Saudi FDA. And we can say it, all the glucometer should have an error factor less than 15%. So please, if you have a wrong information or error, a wrong reader, a wrong reading with this glucometer, you can in contact with the company to make sure it is accurate or not. But we cannot recommend any machine on top of the other. طيب الله يعطيكم العافية. I think this is the last question in Q&A. Thank you for all. And inshallah, after 2 minutes, we can start our next lecture, inshallah. أهلا وسهلا فيكم مرة أخرى. And other next presentation about the hypoglycemia in patient with diabetes. We start by this case in patient with diabetes. Muhammad is a 48-year-old male. He is referred as a case of uncontrolled diabetes. He is diabetic for 12 years. His BMI is 36, and clinical examination were unremarkable for this patient. There is no regular home monitoring. He is in metformin, 1,000 or 1 gram BID, glycoside 60 milligram once daily, glipnicolamide 5 milligram TID, and also he is in Lantus 42 international unit once daily. About the lab work, his hemoglobin A1C is 11, CBC and liver function test were normal, creatinine is 321, and eGFR was 19. What is the most important question you will ask this patient? We need your participation, please, for this question. What's the first thing coming in your mind if this patient is with these characteristics coming to your clinic? Okay, this patient, okay, I agree, it is poorly controlled diabetes. His A1C is 11, but the cause is, or the reason why his A1C is high. This patient, unfortunately, in glycoside and glibenclamide, there is 2-sulfonylurea, and also he is in Lantus, and also he is in metformin. All these medication causing the hypoglycemia. Unfortunately, this patient, his eGFR is 19. He is in a 4th degree of end-stage renal disease. By all this medication, the metformin should not be prescribed, the glycoside and the glibenclamide, and also a huge dose of the Lantus. So this patient actually is in a hypoglycemia. By recurrent hypoglycemia, he is into a hypoglycemia, and by indirect, he tried to compensate this hypoglycemia to prevent the hypoglycemia by eating. So the patient will be in a vicious cycle of hypoglycemia, and his A1C is increasing due to rebound to hypoglycemia when they try to prevent the hypoglycemia. So please, in any patient come to you, even though his hemoglobin A1C is high, we should ask them about hypoglycemia. In glycemic target, we have the A1C less than 7, preprandial from 80 to 130, and peak postprandial less than 180. We try to control or try to prevent the hyperglycemia, and also we try to prevent the hypoglycemia in any patient with diabetes, any patient when we treating them for diabetes control. What is the hypoglycemia? Hypoglycemia is all episode of abnormal low plasma glucose concentration that expose the individual to a potential harm. This is the general definition of the hypoglycemia. And usually it is if the plasma glucose concentration less than 70 milligram per deciliter as used as a cutoff point for classification of hypoglycemia. The hypoglycemia usually have a Whipple triads. Whipple triads is the development of a neurogenic or neuroglycopenic symptoms, which is the classical symptoms of hypoglycemia, low plasma glucose, which usually less than 70, and the resolution of these symptoms after glucose concentration is raised. So this is the Whipple triad, and it's available in most patients with hypoglycemia. Hypoglycemia is common in type 1, and also it is common in type 2. In type 1, there are 2 episodes of symptomatic hypoglycemia per week, and usually there is 1 episode of severe hypoglycemia at least annually. Hypoglycemia also is frequent in type 2 diabetes, but is less frequent than type 1 diabetes. But over the time, the frequency of hypoglycemia in type 2 diabetes approach that in type 1 diabetes. Why that? As we see, in type 2 diabetes, from the early start of type 2 diabetes, it is less hypoglycemia, but as the progression of type 2 diabetes, it's leading to a higher prevalence of hypoglycemia, and it is related to the defect in counter-regulatory hormone of the hypoglycemia response. And after 5 years of developing type 2 diabetes, it's actually as a diagnosis of type 1 diabetes, their risk for hypoglycemia. And as the duration of diabetes was increased, the risk of hypoglycemia is increased. In type 1 diabetes, almost, most of them, more than 83% of patients developing at least one episode of hypoglycemia, and around 14% of them developing severe hypoglycemia for the 4 weeks of the study. In type 2 diabetes, there is around 47% of patients with type 2 diabetes developed at least one episode of hypoglycemia for the 4 week of the study. And only 9% of them having the severe hypoglycemia within the 4 weeks. So the prevalence of severe hypoglycemia for just a 4 week, it is a 14% in type 1 diabetes and 9% in type 2 diabetes. That means we have a huge or a high prevalence of hypoglycemia in both type 1 and type 2 diabetes. What is the physiological response to decrease plasma glucose concentration? How can the body overcome the hypoglycemia? The first, the body starts by reducing the insulin secretion to a defensive mechanism against the hypoglycemia. And after that, after the blood sugar was decreasing, the body tried to compensate the hypoglycemia by increasing the counter-regulatory hormone in the form of glucagon, epinephrine, cortisol, until the patient reaches his blood glucose less than 50. The symptoms will start to change. The symptoms start to be happening in the patient, and the cognitive function usually it changes if the blood sugar less than 50. And those patients with less than 50 hemoglobin, less than 50 blood glucose, they have the cognitive function change, the mental status change, and the dizziness, and there is loss of concentration, and sometimes reaching to or ended by coma, or some patient will be died due to the hypoglycemia. The symptoms of hypoglycemia either neurogenic or neuroglycopenic. In neurogenic, we have trembling, palpitation, sweating, anxiety, anger, nausea. All these are autonomic symptoms for hypoglycemia. Also, we have neuroglycopenic, which is difficulty in concentration, confusion, weakness, drowsiness, vision change, difficulty speaking, and dizziness. This is usually in the late stage of hypoglycemia, when the body there is no glucose entering the brain. What is the cause of hypoglycemia? We have a frequent or multiple causes of hypoglycemia in type 2 diabetes, and usually that causes of hypoglycemia in type 2 diabetes is inadequate or missed meal or a snack. So it is important to educate our patient about importance of diet when they are treating their diabetes. Excess physical activity, either unplanned or more prolonged than usual. Too much insulin or sulfonylurea administration for the patient with diabetes, leading to hypoglycemia. Insulin administration error, mistaken by type or dose or time. Some patients may be mistaken by type. This type, for example, if the patient takes the basal insulin for one time and he forget to take it again with the meal, or the duration, the patient maybe take his dose 2 times instead of 1 time, or the patient may increase the dose by increasing the dose of insulin, or the patient have a problem with insulin injection technique, injection site causing variable insulin absorption, malabsorption and gastroparesis, and this has caused late hypoglycemia. Abrupt discontinuation of glucocorticoid. If the patient in a higher dose of glucocorticoids, they had the insulin resistant, but if they had a sudden or abrupt discontinuation, the body tried to gain their sensitivity to insulin, and if the patient continues the same dose of insulin, he will develop the hypoglycemia. Renal or hepatic impairment, as our case when he developed renal hypoglycemia, renal impairment, he developed hypoglycemia. Other medical problem, for example, Addison disease, celiac disease, all these are risk factor for hypoglycemia. And please, for any patient with type 1 diabetes present to you with unexplained hypoglycemia, you should screen about Addison disease and celiac disease. What about the risk factor for severe hypoglycemia? If the patient is treated with sulfonylurea or insulin. Now we talk about the severe hypoglycemia when the patient needs assistance from the other to controlling this hypoglycemia. Its main risk factor is prior episode of severe hypoglycemia. If the patient had previous severe hypoglycemia, if the patient strictly control of blood sugar less than A1C less than 7, if he had hypoglycemia and awareness, longer duration of insulin therapy, as we said, by longer duration, the counter-regulatory hormone will be changed, autonomic neuropathy, chronic kidney disease, low economic status, low health literacy, and preschool in children, which they are unable to detect or treat their hypoglycemia, in adolescent, pregnancy, elderly, and cognitive impairment. All these risk factors as a risk for severe hypoglycemia. Classification of hypoglycemia, we can classify it to both to level 1, which is the hypoglycemia alert value, level 2, which is the clinical significant hypoglycemia, and level 3 with severe hypoglycemia. In level 1, usually the blood sugar from 70 to 54, and the level 2 blood sugar is less than 54. But in severe hypoglycemia, there is altered mental or physical status requiring assistance from the other to controlling their hypoglycemia. What about the severity of hypoglycemia? It is mild, moderate, or severe. In mild cases, there is autonomic symptoms present and individual able to self-treat. In mild, there is autonomic and neuroglycopenic symptoms, and individual also is able to treat. In severe, there is autonomic and neuroglycopenic symptoms also, but the patient is require assistance from the other to controlling their blood sugar. And also, the plasma glucose is typically less than 2.8 millimole per liter. What is the classification of diabetes? As after we know the diagnosis and the risk factor for hypoglycemia and the classification of severity, and nowadays, what's the type or classification of hypoglycemia? Does if the patient had complaint of hypoglycemia, all the hypoglycemia the same if the patient is complaining of that or not? Now we will talk about the classification of diabetes depending of ADA guideline and endocrine society work group, which was done in 2013. They have the severe hypoglycemia, documented symptomatic hypoglycemia, asymptomatic hypoglycemia, probable symptomatic hypoglycemia, and pseudo hypoglycemia. In severe hypoglycemia, the patient required assistance from another person to effectively administer carbohydrate, glucagon, or take other corrective action. In a plasma glucose concentration, may be not available due to an emergency situation, so the blood glucose could be not available. But there is a neurological recovery following the return to plasma glucose normal is considered efficient or sufficient evidence that the event was induced by low plasma glucose concentration. So in severe hypoglycemia, the patient had complaint of neuroglycopenic symptoms and resolved the symptoms after correction of plasma glucose. The other documented symptomatic hypoglycemia, the patient had typical symptoms of hypoglycemia plus documented hemoglobin A1 plus documented plasma glucose by less than 70 milligram per deciliter. Asymptomatic hypoglycemia, and usually this patient is unaware of hypoglycemia since there is no symptoms of hypoglycemia, but when they checking their blood sugar, their plasma glucose were less than 70 milligram per deciliter. A probable symptomatic hypoglycemia, typical symptoms of hypoglycemia, but the patient not checking their blood sugar. Pseudohypoglycemia, And this is common in our practice. The patient come to you, I'm feeling tiredness, I am feeling palpitation, I am feeling symptoms of hypoglycemia. But when you check blood sugar for them, that you found that blood sugar is more than 70. So this is called pseudo hypoglycemia. And also we have hypoglycemia and awareness, which is characterized by presence of cognitive symptoms in the absence of autonomic symptoms. The patient complaining of cognitive symptoms, but there is no autonomic symptoms. And usually those patients not aware about the hypoglycemia till they reach the severe hypoglycemia. Since the first sign, mostly the first sign of the hypoglycemia in those patients were confusion or comatose. The other type, we have the hypoglycemia associated autonomic failure, which is characterized by a defective glucose counter regulation. And the hypoglycemia and awareness result in attenuated increase in asympathoadrenal activity. So those patients with HAF, which is the hypoglycemia associated autonomic, there is no counter-regulatory hormone. Also, there is asymptomatic, no symptoms of hypoglycemia. So this leading to a vicious cycle of recurrent hypoglycemia. The patient developed hypoglycemia and he is not aware of hypoglycemia, no counter-regulatory hormone of hypoglycemia, then developed hyperglycemia and hypoglycemia, and they enter in this vicious cycle. To reverse this hypoglycemia associated autonomic failure, we need to relaxation of blood sugar control for those patients. We elevate our target for them for both fasting, postprandial, and hemoglobin A1C for 2 weeks, and after the patient restore their ability to control or ability to feel about the hypoglycemia symptoms. As we see, and as we discussed, hypoglycemia associated with autonomic failure, it's both defective glucose counter regulation and hypoglycemia unawareness. Usually, when there is hypoglycemia, the body starts to release of hormone. After that, the body tries to compensate this hypoglycemia by warning symptoms, autonomic symptoms, and ended by cognitive impairment as neuroglycopenic symptoms happened. How can we improve the glucose awareness for hypoglycemia? If the patient is not aware about the hypoglycemia, there is no symptoms of hypoglycemia, we should avoid the recurrence hypoglycemia. This is the one, and we should relaxation on the strict control of their blood sugar for those patients with diabetes and frequent hypoglycemia, and also give the patient advice about the frequent snack to prevent the recurrence of hypoglycemia. And also, it is important to check their blood sugar regularly to check any hypoglycemia and treat accordingly. And also, we need to educate the patient about the psycho-educational program, since when the patient developed hypoglycemia, he will be keeping anxious and fearing from recurrent hypoglycemia, especially in severe hypoglycemia. In exercise-induced hypoglycemia, we should this leading to increased absorption and increased insulin resistance, leading to depletion of glucose storage and exercise-induced counter-regulatory hormone deficit. Hypoglycemia risk may be increased in both at the time of exercise and also in the 24-hour following the activity. So please, if you have any patient who had hypoglycemia during the exercise or just after the exercise, educate this patient to follow this patient and educate the patient to do regular and continuously home monitoring for the next 24 hours to avoid the recurrence of hypoglycemia. During the prolonged exercise, ingestion of 15 grams of carbohydrate may be appropriated. For those patients who is in a prolonged exercise, they will be advised to use 15 grams of carbohydrate to prevent the hypoglycemia during the exercise. Another case, we have this simple case, which is 13 years old girl. She has type 1 diabetes for 5 years. She is on basal insulin 35 and aspart 8 units with breakfast and 10 units with the lunch and 8 units with the dinner. The mother come to you for controlling of blood sugar to follow up of her diabetes. When you take the comprehensive history for this patient, the patient said, well, yes, this lady or this girl complaining of nighttime MERS, and this is her home reading. What do you think for this patient? What is the reason for nighttime MERS? And the question you need to be asked for her. This patient could have a nighttime hypoglycemia, which is the risk factor for nighttime MERS is the night hypoglycemia. We should, or we must advise this lady to check the blood sugar during the early morning and at a Fajr time to check if there is any hypoglycemia for her lady. Nocturnal hypoglycemia, which is common in patients, especially in patients with type 1 diabetes. And we have 16% of patients reported nocturnal hypoglycemia in the past month, which is done in this trial. They found that risk is highest in type 1 diabetes, but around 1/3 of type 2 diabetes are having the hypoglycemia, especially those treated with sulfonylurea. Most events occur between the midnight and 2 a.m. and around some of them in 2 to 4 a.m. So around 50% in the time of 2 to 4 a.m. Half of all severe hypoglycemia event during night. So the most severe hypoglycemia coming during the night. So it is important to educate our patient to check if they are at risk of hypoglycemia, to check their blood sugar before they going to sleep. What is the impact of nocturnal hypoglycemia? The impact for that, the sleep will be disturbed, and there are around 1 hour loss in the sleep for those patients, for the patient and for their caregiver, and 50% of patients or of parents are awakened by events. Majority feel fatigued, 20% reduce, avoid driving, and 10 to 30% miss work time. This is all this complication of nocturnal hypoglycemia. They can affect their work time, and they can affect their lifestyle. They can affect the quality of life and the patient feeling of fatigue and avoid the driving. And also the steps of glucose checking was increased for those patients with recurrent hypoglycemia. Nocturnal hypoglycemia, due to that, 7% of patients hurt themselves by falling, and cost of nocturnal hypoglycemia have been estimated to be more than $127 per event. So all this as a complication or a side effect or an impact of developing hypoglycemia. So it is important to prevent any patient from developing the hypoglycemia and to make sure we controlling blood sugar. In we controlling blood sugar, we try to control hyperglycemia and prevent the patient from developing hypoglycemia. What about the A1C and hypoglycemia? As we said from the first patient, the hypoglycemia, the patient come to you with hemoglobin A1C is 11. That's not mean this patient is in safe place for hypoglycemia. No, this patient could have hypoglycemia and they should to be asked for hypoglycemia. Any patient with diabetes, he is on insulin or sulfonylurea, we should ask them about hypoglycemia in each visit. Hemoglobin A1C does not provide a measure for glycemic variability of hypoglycememia. Just give a mean of plasma glucose for the past 2 to 3 months. For patient prone to the glycemic variability, glycemic control is best evaluated by a combination of result from hemoglobin A1C, self-monitoring blood glucose, and continuous glucose monitoring. So if you think this patient has a variable blood glucose, we recommend to use the continuous glucose monitoring to controlling or to assessing the variability of glycemic control. Hemoglobin A1C may also confirm the accuracy of the patient meter or the patient reported home reading result and the adequacy of home reading result testing schedule. So usually we try to matching the result of hemoglobin A1C to the result of average of home reading. See, this is the example of variability. All those patients having the same hemoglobin A1C of 10. But as we see, the glucose variability, the hemoglobin A1C for those two patients is 8, but the glucose variability, we have different glucose variability. Let's say for the patient with low glucose variability, his blood glucose have hypo and hyper, but the hyper is almost, he have some hyper, but the hypo, it's not less than 50. It's around maybe one time he developing the hypoglycemia. But the other, he is in above range. Yes, it's above range target, but mostly is in a high range or above blood glucose target. In the other hand, with high glucose variability, we saw this patient developed a higher hypoglycemia, multiple hyperglycemia, and also hyperglycemia is increasing, multiple reaching 400 and more. Unfortunately, both two cases giving the hemoglobin A1C of 8. So please, the hemoglobin A1C of 8 or hemoglobin A1C result not make this patient is not risk for hypoglycemia. We should ask about our patient about the hypoglycemia. So monitoring our glucose, we have the home reading, CGM, and the flash glucose monitoring. In CGM, its advantage is familiarity, accuracy, and low cost. All the patients know about how to checking their blood sugar. Their limitation is inconvenient, it's difficult, pain, antisocial, and sporadic. How does the patient, for example, the child, how can he checking his blood sugar, for example, 7 times per day? About the CGM, it's a full glucose profile, give us a full glucose profile for all the day. Any hypoglycemia, any hyperglycemia, he will be picked and recorded. And also alarm for hypoglycemia and IB connection. We can connect it with a healthcare provider or connect it to other family to controlling or seeing the result of their home reading. The limitation is the main limitation is the cost and calibration in some machine need to be calibrated regularly. And interpretation actually need to be mostly need to be interpretation by a healthcare provider. In a flash glucose monitoring, which is the mainly nowadays we have becoming the Freestyle Libre, which is the available in MH. Its advantage is a full glucose profile, no need for calibration, and it is affordable and less expensive than continuous glucose monitoring. The limitation, there is no hypo alarm, and there is a connection to IB when they are implement their application. What's the consequence for hypoglycemia? The hypoglycemia, recurrent of hypoglycemia, leading cognitive, psychological changes, and the negative impact on quality of life. As we say, they may be miss their work, they may change in their life. The accident and fall was increased in those patients with hypoglycemia, recurrent hypoglycemia leading to hypoglycemia and awareness, refractory diabetes by hypo and hyperglycemia, dementia, especially in elderly, and cardiovascular event as a complication of hypoglycemia. And in a late stage or a difficult advanced stage of hypoglycemia can leading to death from the hypoglycemia. What is the impact of hypoglycemia and quality of life? As we say, the patient, when he developed hypoglycemia, they fear from the recurrent hypoglycemia, and the patient become morely anxious most of the time about their hypoglycemia. And also it is leading to a chronic mood disorder, including depression and anxiety, and the hypoglycemia linked to reduce the productivity of the patient. It is important to know that when we're treating the hyperglycemia, to individualize our target for glycemic control for patients with diabetes, to treat the hyperglycemia and prevent the patient from developing the hypoglycememia. We have a different factors when we're treating the hypoglycemia, as we see in the previous slide. With this is that determination of individualization of blood glucose control. What is the strategy? We know to prevent the hypoglycemia, we should educate our patient about the dietary intervention, exercise management, medication adjustment, glucose monitoring, and clinical surveillance. All of these should be modality of management to prevent the hypoglycemia in developing a patient with diabetes. In education, we should advise our patient about and family and their family, and also the caregiver about preventing the diabetes and recognize the symptoms of diabetes and how to treat the hypoglycemia when it's developed. And also it is important to report any episode of hypoglycemia to your doctor or to your physician. About the diet, we should give the patient a balanced diet, carbohydrate, protein, and fat. And also if the patient is on long-acting secretagogue and fixed insulin regimen, must be encouraged to follow a predictable meal plan, and a planned meal should be offered for those patients. But if the patient is in not planned or non-predictable meal, the best modality of insulin treatment or modality of insulin approach for them is multiple daily injection or basal bolus injection. Patient on more flexible insulin regimen must know that prandial insulin injection should be coupled with meal times and carb count. It is important to couple them with each other, the insulin injection with the meal. Patient on any hypoglycemia-induced medication should also be instructed to carry carbohydrate when with them at all time to treat hypoglycemia. And it is also important for any patient with recurrent hypoglycemia, we advise them to take the carbohydrate, simple carbohydrate with him, and also to inform their caregiver, and also to inform their relative or inform their colleague in their work. Exercise management, physical activity increases glucose utilization and increase risk of hypoglycemia. Exertional hypoglycemia include prolonged exercise duration and inadequate energy. So we need to monitor blood glucose before, during, and after exercise. And pre-exercise snack should be ingested if the blood glucose value indicate falling glucose level. If the patient in lower normal of blood glucose, they should be take a snack before starting the exercise to prevent the hypoglycemia during the exercise. And prolonged exercise, we need to ingest 15 grams of carbohydrate during the prolonged exercise. Modify physical activity that caused the hypoglycemia in the past. If the patient had experience with hypoglycemia with some types of physical activity, so the patient should be modify these physical activity. Medication adjustment is important to adjust the medication by agreement with the doctor, depending on the medication need and depending on the risk of hypoglycemia with this medication. Consider change insulin type or regimen for regular insulin to rapid acting insulin, NPH to insulin analog, basal insulin analog, and also to adjust insulin in relation with exercise and intercurrent illness, depending on the patient situation, and should be the time and the dose adjusted for the insulin. So about the medication should be adjusted depending on the patient, depending on the risk factor of the patient, and the side effect of hypoglycemia as the medication side effect. Glucose monitoring, it is important to review the glucose monitoring regularly and to recognize the symptoms and to check the blood glucose to find any hypoglycemia. Especially the home reading is advised for any patient treated with insulin and if the patient has had a recurrent hypoglycemia. In clinical surveillance, we usually need to assess the risk of hypoglycemia every visit with patient treated with insulin or insulin secretagogue, how often the patient is experiencing symptomatic and asymptomatic hypoglycemia, ensure the patient is aware about how to appropriately recognize and treat hypoglycemia, remind both parties of the risk associated with driving while hypoglycemia. So in treatment of hypoglycemia, we have two approaching or two arms when treating of the hypoglycemia. As we said, hypoglycemia associated with symptoms and blood sugar less than 70. If the patient is conscious and alert, please use the rule of 15. Rule of 15, that means consume 15 grams of carbohydrate, of simple carbohydrate, and recheck after 15 minutes. If the blood glucose is reaching the target, it's more than 70 milligrams per deciliter, take the snack. And if the blood glucose level less than 7, repeat the rule of 15 again by taking more 15 grams of carbohydrate and recheck blood sugar after 15 minutes. So this is the rule of 15 for any patient who is conscious and alert with hemoglobin with blood sugar less than 70. On the other hand, what about if the patient is severely confused or unconscious? Those patients require a glucagon injection delivered by another person, and the patient should be taken to a hospital for evaluation and treatment after any severe episode, and those patients should be taken 150 to 200 ml of 10% glucose over 15 minutes. Actually, we have a live patient with this before 2 to 3 days. During the night, it's around 12 a.m. One of my patients called me. They told me my mother, she is diabetic and followed with me. They found them at the bed, supine and unconscious. What we will do for him? And they check their blood sugar. They found that their blood sugar is around 35. What is the best approach for them? I advised it to them to give her the glucagon. Since I try to prescribe the glucagon for any type 1 diabetes, any long-standing diabetes type 2 with a risk of hypoglycemia. So they inject there with glucagon injection, and she regaining her weight after 5 minutes. This is the importance of the glucagon. You can save the life of the patient by prescribing the glucagon for them. So please, any patient at home, you can advise him to take the glucagon if they are not aware or unconscious, and to give him a 10% glucose if the patient is reaching the hospital or a healthcare institute. In 15 gram simple carbohydrate for those patients is alert and conscious, we have 3 teaspoons or 3 buckets of sugar dissolved in water, 150 ml of juice or regular soft drink, and we have 15 ml, which is the tablespoon of the honey. All these are the example of 15 grams of carbohydrate, usually 3 teaspoons of simple sugar or 1 tablespoon of the honey. And if the patient had any candy or he has any glucose tablet, they take 15 grams of carbohydrate, which is the simple carbohydrate. So this is a question. If you had a patient with hypoglycemia and only have these products, which one you will use to control this hypoglycemia? We have chocolate, either Snickers, Mars, and also we have other snacks, which is, for example, it's Luzine, and we have Pepsi Diet, and we have regular Pepsi. If you have one patient with hypoglycemia and you just have these 4 types of snacks, which one you prefer to give to your patient to control this hypoglycemia or to treat hypoglycemia. Okay, we have a lot of answer. Thank you for this participation. And most of them said about Pepsi, and some of them said chocolate and sneaker. We need to thinking. Yes, exactly. We need to thinking for that. And some of them said it's leucine. We said in the management of hypoglycemia, we need 15 gram of simple carbohydrate, 15 gram of simple carbohydrate. We take it one by one. What about the Pepsi diet? Pepsi diet is a zero carb. Pepsi diet is a zero carb. So we cannot treat the hypoglycemia with this Pepsi diet since there is no carb. And we treat the hypoglycemia by a simple carb. So the Pepsi diet will be excluded. The other thing about the Snickers and Mars, which is the chocolate, this chocolate having the fat, and the fat, as we know, the fat delay the absorption of the glucose, and protein that delay the absorption of glucose. So we need time to control, or need time to manage, need time to treat the hypoglycemia. What about the leucine? Leucine also had a protein and had fat. A protein causing more secretion of the insulin and delayed the absorption of insulin. So the patient will become more on the hypoglycemia. What about the Pepsi diet? Yes, the Pepsi diet had a simple carbohydrate and a simple sugar. We can give the patient a special amount or a small amount of Pepsi diet with since it has had a simple carbohydrate to controlling their blood sugar. So I hope you get this point. For this patient, we need to assemble carbohydrate and assemble sugar to controlling the hypoglycemia. Pure glucose. We need pure glucose. Again, we need pure glucose. Pure glucose, which is available in regular Pepsi. Other than pure glucose here in regular Pepsi, there is glucose, yes, carbohydrate, and there is fat and protein. Here is glucose, fat, and protein, and there is no carbohydrate, no glucose. So the Pepsi, regular Pepsi, is the best choice from these elements. In type 2 diabetes, ingest protein may increase the insulin response without increasing the plasma glucose concentration. Therefore, carbohydrate source high in protein should not be used to treat or prevent the hypoglycemia. What about the glucagon? The glucagon, use of glucagon is indicated for treatment in a patient with hypoglycemia in people unable to willing to consume carbohydrate. A glucagon, we have a glucagon, simple bin, should be diluted and should be administered for all patients. And as we use this glucagon in emergency situation, all these steps on how to prepare and how to inject is available in the same bin, as we said here from the same box. There is how to inject and how to prepare this glucagon. Usually the glucagon we can give 1 milligram for adult who is the age more than 12 or his weight more than 20. And if the age is less than 12 or the weight is less than 20 kilogram, we can give the half the dose. A glucagon should be prescribed for all individuals at increasing risk of hypoglycemia. a glucagon administration is not limited to a healthcare professional. So it is educated. Usually the glucagon should be given at the home, at the school, at the work, not given for the hospital. In the hospital, we can give the dextrose 10%. Ensure the glucagon kits are not expired. When we prescribe the glucagon for any patient with diabetes, we should regularly ask them to assess the expiry date for the glucagon to prevent the expiration. And if it is expired, we can renew the prescription for them. So the steps in addressing the hypoglycemia: by recognizing autonomic neuroglycopenic symptoms, confirm if possible if the patient is aware for checking their blood sugar, and treat with fast sugar, simple carbohydrate, 15 grams of carbohydrate to relieve the symptoms, and retest in 15 minutes to ensure blood glucose more than 70. And if it is less than 70, we need to repeat the rule of 15 again and eat usual snack or meal due to that time. Or snack of 15 grams carbohydrate plus protein after we reaching the plasma glucose more than 70. If the patient is unaware of the patient, or if the patient is comatose, we can use a glucagon injection. It is almost, remember, and one of the most recommendation when treating the hypoglycemia, treat, but don't over-treat. Treat, but don't over-treat. What that mean? Usually when the patient develops hypoglycemia, one give him the chocolate, one give him snacks, one give him sugar, one give him juice, one give him. The patient from the hypoglycemia, he will be shouting to a severe hyperglycemia. So please, in any patient with hypoglycemia, just give him 15 grams carbohydrate, not more than that, and recheck after 15 minutes. If the patient is comatose, give him the glucagon to control this hypoglycemia. Remember, treat, but don't over-treat. And also to remember that 4 is the floor. That means when the hemoglobin A1C reaching the 70 milligram per deciliter, the patient soon will be reaching the floor and will be comatose. Thank you for all. And now the time for discussion and any question or comment for you from this lecture. If you have any question, please put it in the Q&A bottom. There is one question. Is it true that diabetes medication cause Mediterranean anemia and osteoporosis in the future? Actually, this is still from the theoretical, not proven. There is no risk, no conclusion for that. And also the complication of diabetes is more dangerous than Mediterranean anemia. So we try to controlling our diabetes to prevent the complication of diabetes. The other question, some patients report hypoglycemia symptoms while blood glucose 80 to 100. Could it be a real hypoglycemia? And it was corrected by counter-regulatory hormone. It's usually if the patient complain of hypoglycemia symptoms with hemoglobin with plasma glucose more than 70, it is called pseudo-hypoglycemia. And this patient need to be take a snacks free from carbohydrate to the symptoms will be resolved. Is glucagon better than concentrated glucose? Usually, glucagon can be given to the patient in comatose state. The patient cannot tolerate it orally. But if the patient tolerated orally, we can give him the rule of 15 as best, either the form of sugar, the form of juice, or the honey. But glucagon, if the patient is unable to tolerate it orally. Does the pre-diabetes patient go to hypoglycemic condition? Yes, most of the patient in pre-diabetes, they develop the reactive hypoglycemia or pseudo-hypoglycemia. They feel of hypoglycemia, but blood sugar is within their normal. I mean, IFE glucose. IFE glucose, okay, as we said, IFE glucose in the hospital institute, in the healthcare institute, and the glucagon outside. This is the difference. Usually glucagon, we cannot prescribe a glucagon for those patients in the hospital. but we prescribe the glucagon for the patient outside the hospital. In the hospital, we can give him the IV glucose. Okay, I think there is no more question. Thank you for all. And inshallah, we have a 5-minute break. And we know in your schedule there is a long break, but for your time, we can have a 5-minute break. After that, we go to the next lecture, inshallah, which will be simple and do not take more time, inshallah. Before conclude, there is one question. أيهما أفضل العصير أو العسل في حال عدم توفر إبرة جلوكاجون? We prefer 15 grams of carbohydrate. If you can take it from عصير juice, it's okay, or from honey is okay. فكل من الاثنين سواء عصير أو عسل اللي احنا نحتاجها 15 جرام of simple carbohydrate. كل من الاثنين موجودة فيهم وكل من الاثنين نفس الإفكت. طيب يعطيكم العافية. Again after 5 minutes inshallah we will join you. inshallah, for you. And our colleague after that will continue with you till the end of the last day today, inshallah. And we hope the best for you all. Our lecture is about diabetic neuropathy. Diabetic neuropathy is one of the most common chronic complications of diabetes, and it is estimated lifetime prevalence exceeding half patient with diabetes, they developing or complaining of diabetic neuropathy. The prevalence then increase with diabetes duration, and it is up to 34% after 25 years, as documented by the DCCT trial. They found that more than 35% of patients with diabetes developing the diabetic neuropathy within 25 years of diagnosis of diabetes. As we said, it's around 26% prevalence for type 2 diabetes, and there is 80% of these patients report moderate to severe pain. As we say, even though the prevalence is not so much, but those patients with developing the neuropathy, most of them, more than 80%, had a moderate to severe pain. So they need to initiate or they need to controlling their neuropathic pain. In diabetic neuropathy, we have diffuse neuropathy, which is diabetic distal symmetrical peripheral neuropathy, autonomic neuropathy, cardiovascular, gastrointestinal, urogenital, pseudomotor, hypoglycemia and awareness, abnormal pupillary function, and or mononeuropathy, which is a typical form and isolated cranial or peripheral nerve, and especially cranial nerve, ulnar, median, and femoral perineal, and mononeuritis multiplex radiculopathy or polyradiculopathy, and non-diabetic neuropathy is common in diabetes. They like pressure pulses, chronic inflammatory demyelinated, and radical pulses neuropathy, acute painful small fiber neuropathy. All these neuropathy are associated with diabetes. Today, inshallah, we will talk about the distal peripheral neuropathy, which is the most common, which is the most painful for patients with diabetes. Sensory neuron and their receptor lie usually outside the blood-brain barrier and more vulnerable to injury secondary to diabetes than motor neuron, which is lie within the barrier. So the sensory neuron, which is the mostly affected by the diabetes complication. We have a small unmyelinated neuron, which is responsible for heat and pain sensation. And also we have another fibers called large fiber, which is responsible for touch, pressure, and cold sensation. Usually the diabetes complication affect the small neuron, which is mostly related to heat and pain sensation. Early injury and loss of a small fiber susceptible to energy flux occur in people with diabetes, resulting in symptomatic pain and burning in their feet. And as the disease progresses, large fibers also become injured by the lack of energy source, and individuals experience numbness and loss of position sense in their feet. So as we said, it is the small fiber affecting first, then followed by a large fiber. These signs and symptoms progress from the feet upward into the leg and reflect a distal to proximal fiber loss that is the hallmark of diabetic neuropathy. So the hallmark of diabetic neuropathy, which is the distal neuropathy, and usually and previously they called I'm sorry, and as we said, diabetic neuropathy usually is started from distal to proximal, and they used as a gloves and the stalk. It started from the hand and from the legs and upward with the time if the patient is progressive in neuropathy and progressive in diabetes and control, this leading to upward from the distal to the proximal. Screening of peripheral neuropathy. Usually, asymptomatic screening for neuropathy can be performed rapidly by using a 10-gram monofilament to checking their points of sensation in the patient feet. And also, we use the tuning fork, which was 128 hertz tuning fork over the dorsal aspect of the grid 2 bilaterally to check for the vibration sense. And also in pinprick or temperature, starting distally, as we say, the diabetic neuropathy started from the distal to the proximal distribution. And also we need to check the ankle reflexes. All these elements should be checked in patient with diabetes when we're screening for peripheral neuropathy. As we said, in monofilament to check for the small fiber, and for the vibration and reflexes for check for the large fiber. All individuals should be assessed for diabetic peripheral neuropathy, starting at the diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1 diabetes, and then at least annually thereafter for any patient with type 1 or type 2 diabetes. Assessing should include detailed history and at least 2 sensation and reflex tests. Electrophysiological testing is rarely needed in people with typical sign of symptoms. If the patient is long-standing diabetes, poorly controlled diabetes, and he came with neuropathic pain, so no need for electrophysiology. If we going with description in distal to proximal, bilateral, symmetrical, disease characteristics, diabetes characteristics, and all of these going to diabetic neuropathy. So no need for referral to neurologist or electrophysiological. A complex differential is recommended in an ambiguous or atypical case should be referred to neurologist or have additional testings. If the patient came with unilateral or there is no explanation for that, the patient is just diagnosed with diabetes with severe neuropathy, and if there is not characteristics of diabetic neuropathy, at this time we should refer them to a neurologist to make an extensive evaluation for those patients to make sure that diagnosis for this neuropathy. So how can we approach any patient with diabetic neuropathy? If the patient come to us to our clinic and complaining of neuropathic pain, how can we approach those patients? The first, we need to take a targeted history for diabetes and diabetes complication. Poor glycemic control, longer duration of diabetes, older age, tall stature, presence of hypertension, presence of obesity, and metabolic syndrome. All of these are risk factor for diabetic neuropathy. We should take in consideration all these risk factors and assessing and ask the patient about all these risk factors. In addition, a history of recent fall, particularly if the patient don't have any other risk for fall at that time, may reflect the gait disturbance, which is related to a large fiber dysfunction associated with diabetic peripheral neuropathy. After the history, we should assess the symptoms, which is the symptoms of large fiber and the small fiber. In large fiber, we have the symptoms, usually the patient complain of numbness, tingling, or poor balance, or unsteady gait. It is usually responsible for large fiber. The sign on examination, we need to check for ankle reflexes. There is usually reduced or absent ankle reflexes. Vibration sense, either reduced or absent. Also, we need to check for the monofilament sensation and proprioception, which is the position sense for those patients to check their large fiber. In small nerve fiber, which is the responsible for pain and for heat. In pain, there is maybe burning sensation, electric shock, and stabbing. The patient sometimes said it is like a pin or like an electric shock, or hyperalgesia. The patient complaining there is a hyperalgesia, there is a high sensation when anything, a high response to any stimuli that not regularly causing the stimulus. And also allodynia, that means the bedclothes, the patient complaining from the bedclothes, they say to you, please, when I sleep, just when the bedclothes come on my feet, I complaining the pain is severe pain for me. All this is related to small nerve fiber. And we need to examine this by a thermal discrimination, cold and hot. It usually reduced or absent, and also by the pinprick sensation, and usually it's reduced and absent in those patients with a small fiber dysfunction in patients with diabetic peripheral neuropathy. Then we need to differentiate the diagnosis. Does it related to the diabetic neuropathy, or it is related to other neuropathy not related to diabetes? Since we have a lot of disease or a lot of syndromes causing neuropathy. For example, metabolic disease, thyroid and renal could be associated with neuropathy. Inflammatory disease, a chronic inflammatory demyelinated polyradiculoneuropathy, and alcohol, amiodarone, chemotherapy, all these causing neuropathy. Systematic disease, vasculitis, paraproteinemia, amyloidosis, and nutrition could be related to vitamin B12 deficiencies and not related to diabetes per se, and thiamine deficiency, tocopherol, and the heavy metal for arsenic and mercury. Infectious disease like HIV, hepatitis B, Lyme's disease, and industrial agent, acrylamide, organophosphorus agent, or it is hereditary or genetic, and it is usually associated with the patient. He complained, or he told you that his father, for example, or his mother developing the same things of neuropathy for a long time. And all this is differential diagnosis of diabetic of neuropathy that arise during the time of diabetes. So the stepwise approach to screening and diagnosing diabetic peripheral neuropathy, we start by taking a good history for the patient with diabetes. Does the patient at risk for developing the diabetic neuropathy? Long diabetes duration, older age, metabolic syndrome, obesity, hyperlipidemia, tall stature, social determinant of the health, and the frequent fall. All these are targeted history for the type 2 for the diabetic neuropathy. Then we assess the symptoms. The large fiber and the small fiber. Is the neuropathic pain present? Burning, lancing, shotting or electric shock-like, worse at night, hyperalgesia. Are the symptoms of large fiber present, which is the numbness, poor balance, weakness, unsteady gait? All these are symptoms of diabetic neuropathy. Then we need to assess for the clinical signs of diabetic neuropathy. Reduced or absent these symptoms by checking these symptoms. Does it reduced or absent? Cold temperature sensation, pinprick sensation, and vibration sense, touch sensation, and ankle reflexes. If the patient is diabetic neuropathy, all these sensation or all these tests or reflexes should be diminished or absent. After we make sure the diagnosis of diabetes, we should develop the differential diagnosis. Assess factor as a symptoms and sign distributed in a symmetrical, length-dependent, stocking and glove pattern, and this is the characteristics of diabetic neuropathy. If it is Yates, so it is diabetic peripheral neuropathy, we can treat depending on that. If it is not, or not asymmetrical, not length dependent of the diabetes, or not in the form of a stocking and gloves pattern, we need to refer to a neurologist to confirm the testing and make sure the type of diabetic of the neuropathy for this patient. How can we treat if we make sure this patient is diabetic neuropathy, and we need to treat them accordingly? First of all, we need to do the pain assessment. As we called before, it is large fiber and small fiber. We have a different modality in assessing the pain, a different score. We can use any score for the pain assessment, or just by asking the patient, does this pain affect your quality of life or not? Does it prevent you from sleep? Does it prevent you from work? prevent you from any other things. So if the pain affects the quality of the life of the patient, we can say that's a severe diabetic neuropathy. What is about role of glycemic control? Chronic hyperglycemia is a major contributory factor in etiopathogenesis of diabetic neuropathies. However, the importance of glycemic control in the management of painful symptoms is less clear. What's that mean? It means the chronic hyperglycemia, it is the responsible for a neuropathy, not the current level of hyperglycemia. Okay, we try to glycemic control now, but it will not affect or not will be treat the neuropathy unless we try to convince them neuropathy and management of painful diabetic neuropathy. In acute state, we could have acute painful diabetic neuropathy. What's that mean? It is rare, and it's usually before it's called as insulin neuritis. That means when the patient had a high number or a high glycemic, a high blood glucose for a long time, and when we treat them abruptly and suddenly we're controlling their blood sugar, they could have some form of diabetic neuropathy, which is called previously insulin neuritis. Why they called insulin neuritis? Since before they are mostly uncontrolled till they use the insulin. When they use the insulin, the patient is dramatically improved. In a short period, they are improved. So they called it insulin neuritis. But later on, they say that a treatment-induced neuropathy of diabetes, since the insulin is not only the cause. So for any patient with a high, or if the patient is a poorly glycemic control, when we abrupt or a sudden controlling their blood sugar, could have some form of neuropathy, and this form of neuropathy will be resolved spontaneously, usually within 1 year, regaining their neuron sensation. About the chronic painful diabetic neuropathy, as we said, it's common type 1 and type 2, and this is common in type 1 and type 2, and require treatment and commonly used therapeutic approach, as we describe, inshallah, in the next slide, the modality of treatment for those patients. And it's need years to regaining their sensation and to resolve their severe symptoms. In therapeutic approach, the treatment approach target the symptoms, but not alter the natural history of neuropathy. So when we treat any patient with diabetic neuropathy, we concentrated about the symptoms, just resolve the symptoms of diabetic neuropathy, since we cannot regain or alter the natural history of progressive neuropathy. What is the pharmacological treatment for patients with diabetic neuropathy? We have a different pharmacological approach. Mainly, we have pregabalin and duloxetine, which is the two drugs approved by FDA to controlling patient with diabetic neuropathy. And also we have other modality of treatment to controlling patient with diabetes, with diabetic neuropathy. Pregabalin is a calcium channel ligand, and evidence suggests a dose-dependent response with a weaker effect at a lower dose. It can be given twice, or in occasion can given 3 times a day, and most patients require 300 to 600 milligrams per day for symptomatic relief. So the pregabalin is dose-dependent response. As we increase the dose of pregabalin, the patient will be more controlling their blood sugar, more controlling their symptoms of diabetic neuropathy. But we should start regularly and gradually to reach their target and to prevent or to control, to relieve the symptoms of diabetic neuropathy. The pregabalin excreted in the urine, and so the greater caution must be taken in individual with renal impairment, especially with those eGFR less than 45. And adverse effect with pregabalin include dizziness, peripheral edema, and the patient feel of sleepiness. Especially in these doses, these side effects happened in higher doses and in old age. So in any patient, we can start them with a slow doses approach, and we can assess the patient. If the patient is needing to increasing the dose, we can increase the dose every 3 to 7 days. And we increase, if the patient need to increase, we try to give the maximum dose with the night and the lower dose with the morning time. Because of pregabalin additionally has anxiolytic activity, it may be particularly helpful in individuals with marked anxiety, which is not uncommon among people with experiencing neuropathic pain. So we can take the benefit of pregabalin in controlling the symptoms of diabetic neuropathy and also its effect as anxiolytic in any patient with anxiety related to diabetes. Other type of with medication can reducing the symptoms of diabetic neuropathy, which is called the duloxetine. Duloxetine is selective neuropathy, norepinephrine and serotonin reuptake inhibitor, and can be given once daily at the dose of 60 or 120 milligram. Its adverse effect also include the nausea, somnolence, and dizziness among those patients, especially among adult patients with older age. Because it has had an antidepressant activity, it's particularly helpful in people with painful diabetic neuropathy who also have the depressive symptoms. Because the duloxetine and the pregabalin, has a different mode of action, combination of this agent has been used with a good effect in a clinical practice. However, the largest comparative trial did not show a significant differences between the high doses of monotherapy with either agent and a standard dose combination of both. However, there was a trend consistently favor combination therapy over the monotherapy. As we said, pregabalin and duloxetine, both of them as approved from the FDA to controlling the symptoms of hyperglycemia of the diabetic neuropathy. And anyone can be titrated and used as a monotherapy to control that. But sometimes we need to make a combination of these medication. Other types which could be used in some population, which is the tricyclic antidepressant in the form of amitriptyline. Unfortunately, these medication have a lot of side effect, anticholinergic effect, such as dry mouth, urinary retention, and drowsiness. There is warning to use this medication if the patient had ischemic heart disease or the patient had glaucoma. It can be given once daily, usually in the early evening, and the usual starting dose, which is the 25, and increasing to reaching the 150 milligram per day. Other also we have gabapentin. It is a shorter half-life and therefore must be given in 3 times per day to controlling the controlling the diabetic neuropathy. We need 2 titration, and most of the patient requiring more than 1,100 milligram per day to resolve the symptoms of diabetic neuropathy. Side effects also include the dizziness, somnolence, and also occasion gait disturbance with gabapentin. Also the opioid, sometimes used in diabetic neuropathy. Unfortunately, several opioids have been studied and show some efficacy in the management of neuropathic pain in general, but their occasional high risk of addiction, abuse, and sedation, and other complications limit their use in patient with controlling their patient with diabetic neuropathy. Topical therapies. Nowadays, there is a lot of the topical therapies approved for use in diabetic neuropathy. For example, 8% long-acting capsaicin patches can be used and developed and now approved by FDA for the painful diabetic neuropathy. It is has a lot of precautions, and should be applied to the site of the pain, and should be avoided if the patient had active skin lesion, and the application required a suitable infrastructure and to be available, and must be performed in physician office. So these batches should be done by the healthcare provider in the physician office to assess any complication or a side effect that happened when they bought these topical batches. Physical therapy, some clinical trials support the use of spinal cord stimulation in the management of severe painful, but is still not approved from the FDA. What about the alpha lipoic acid? Because the oxidative stress play a major role in pathogenesis of diabetic neuropathy, so there is a rationale to use the alpha lipoic acid to decrease or diminish the enhanced oxidative stress related to diabetic peripheral neuropathy. Alpha lipoic acid is approved and recommended by guideline pharmacological therapy for diabetic peripheral neuropathy in several countries, but it's not approved from the FDA to use in diabetic peripheral neuropathy. The usual dose is 600 milligram per day, but a higher dose, 6 milligram twice or 3 times daily, can be occasionally given for the patient, and useful if the symptoms relief is not partial. If there is less than 30% reduction in the symptoms of patient with diabetic neuropathy, we can increase the dose to 2 or 3 times per day of alpha lipoic acid. Benfotiamine is a lipid-soluble anti-thiamine homologue. It is a synthetic acyl derivative of thiamine, and has been inhibit the formation of AGA, which is the responsible for diabetic neuropathy formation. And it is approved and recommended by the guideline as a pharmacotherapy treatment for diabetic neuropathy in some country, but is still not approved from the FDA for use in diabetic neuropathy. The appropriate dose for it is in the first 6 weeks, it's more than 300 milligram twice daily. What about the vitamin B12 deficiency? What about the vitamin B12? Vitamin B12 deficiency is a hematological and neurological consequences, and including polyneuropathy. And because the increased risk of vitamin B12 deficiency associated with metformin use, the ADA recommend periodic measurement of vitamin B12 level for metformin-treated patient. In vitamin B12 deficiency, should be supplemented with vitamin B12 supplement to overcome this deficiency, and could be given as an injection or oral agent to treat the vitamin B12 deficiency. If we use the oral agent, it should be a higher doses in vitamin B12 with 1 milligram daily, and the duration of supplement depend on the cause of vitamin B12 deficiency. It could be lifelong time if the patient had pernicious anemia or after bariatric surgery. A treatment of diabetic peripheral neuropathy with vitamin B12 deficiency in the absence of vitamin B12 deficiency is not indicated. So not indicated to prescribing vitamin B12 for any patient with diabetic neuropathy unless there is vitamin B12 deficiency. Vitamin D. There is nowadays there is a lot about the vitamin D and the relation of vitamin D to diabetic neuropathy. In a randomized open-label trial, they found that vitamin D deficiency, when they treat the vitamin D deficiency, they saw the improvement in the neuropathic symptoms and deficit. They treat those patients with the 40,000 international unit per week. When they compare to the routine used 5,000 international unit per week, they found that much improvement in diabetic neuropathy symptoms. But still, this study need to be defined the exact role of vitamin D deficiency and the specific dose of vitamin D to controlling the vitamin D deficiency symptoms. In magnesium, there is no evidence for using the magnesium in treatment of diabetic peripheral neuropathy. So in management of patient with diabetic neuropathy, we can assess the patient, evaluate the patient, then use the first line therapy. If the patient is still in control, we can use the second line. In the first line, we have mainly, we prefer to use the pregabalin and gabapentin as the first line, and then proceed the second line. Anyone can use from the second line. And after that, the third line, if the patient is in control, we can refer those patients to a neurologist to be assessed by them. This is the all the available medication used for painful diabetic neuropathy. With these doses and maximum doses we can use. Mainly we have pregabalin, as we said, we can start from 75 milligram, and most patients requiring 300 milligram per day. And gabapentin, sometimes it's reaching 180 milligram per day and divided into 3 doses. Duloxetine, we can start directly from 60 or 120 milligram daily. What about the non-pharmacological approach to diabetic peripheral neuropathy? We have aerobic exercise, resistant and strengthening exercise, balancing exercise, anti-sedentary behavior, and diet modification. All these exercise, they have a mild change or a mild beneficial in diabetic neuropathy. So any patient with diabetic neuropathy, even though we prescribe for them the pharmacological agent, we can advise them to take the lifestyle intervention to improve their quality of life and improve their symptoms of diabetic neuropathy. So any patient with diabetic neuropathy, the first we need to exclude other cause of diabetic neuropathy, and we aim for a good and a stable glycemic control and improve the quality of life for those patients with diabetic neuropathy. About the pharmacologic, we have anticonvulsant in the form of pregabalin and gabapentin. We have SNRIs, which is the duloxetine, and the triglyceride and the tricyclic antidepressant. All these are pharmacological, systematic pharmacological therapy for diabetic peripheral neuropathy. Also, we have topical treatment, which is the capsaicin 8% batches, and non-pharmacological therapy, which is the health behavior, exercise, reduce the sedentary behavior, dietary modification, and energy nerve stimulation could be have beneficial in patient with diabetic neuropathy. A combination of management or a combination is recommended in some patient, either pharmacological plus non-pharmacological or multiple pharmacological approach with pregabalin plus duloxetine can be used in some population, especially if they are resistant to controlling their symptoms of diabetic neuropathy. Opioid, even though there is a positive or there is a good effect on controlling the symptoms of diabetic neuropathy, but we not recommend to use as management of diabetic neuropathy due to the side effect and complication of that. So in conclusion to our talk about peripheral diabetic neuropathy, effective pharmacological therapy for painful diabetic neuropathy include anti-epileptic agent in the form of pregabalin and gabapentin, antidepressant, which is the duloxetine and tricyclic antidepressant, although often effective pain reduction require higher doses that may be less tolerated or have a higher incidence of adverse effect for the patients with diabetic peripheral neuropathy. For those with severe painful symptoms, not responding to a single agent, combination therapy with 2 or 3 agents may be effective at much lower doses, as well combination with pharmacological and non-pharmacological approach. It could be improving the symptoms of diabetic neuropathy. Such patient may have also benefit from referral to a pain clinic and psychiatric clinic if they need for that. Given the high risk of complication and modest evidence for benefit of use opioid, so it is not recommended as management of diabetic peripheral neuropathy. Painful diabetic neuropathy is not uncommon in older patients with diabetes, so the caution must be taken with any prescribed medication, starting with the lowest dose, with slow up titration is recommended in such cases to prevent the complication and side effect of these medication. based on evidence for efficacy in reduction of symptoms and excellent safety from RCT, alpha lipoic acid, and benfetiamine, currently approved in some country, although it's not approved in FDA in the US, so may be added for the management of persistent neuropathic symptoms, including the pain in diabetic peripheral neuropathy. Thank you for all. And it's my last slide in my presentation. Now the time for discussion and any question or comment. Please, any question, put it in the Q&A. There is a correlation between diabetes and the neurological deterioration, nerve conduction, and dementia. Yes, the diabetes is long-standing. Poor glycemic control affect the demyelination, leading to demyelination of the nerve, and usually affect the center, affect the peripheral nerve, and it's related to the dementia. Nowadays, the dementia is related mostly due to the hypoglycemia, not related to the hyperglycemia. Any other question? Vitamin B12 to be given injection or oral. Vitamin B12, if there is deficiency for vitamin B12, can we give in either oral or injectable? But we try to give vitamin B12 as oral, we need to give the patient a higher doses. The patient take a regular doses and at least 1,000 microgram twice daily to reach their, to take their benefit from that. But injection, we can give the patient in a separate days and a less doses of injection. So when we try to give the oral, we need a higher doses of vitamin B12 to overcome the vitamin B12 deficiency. Does the same peripheral diabetic neuropathy occur in children with type 1 and how they are treated? In type 1, yes, could be come the diabetic neuropathy in type 1 diabetes in childhood if they are long-standing diabetes more than 5 years, and poorly controlled, especially if they are obese. But alhamdulillah, most of them, even though in the childhood or in the early adolescent, the peripheral diabetic neuropathy is a less, very, very, very rare, and the symptoms usually are less. Okay, any other question? Assalamu alaikum wa alaikum assalam. I think there is no more question. If there is no more question, I would like all of you to attending and participation in this symposium, and also would like to thank the Future Vision to invite me to participate yesterday and today about some topics about diabetes and its complication. And we hope the best for you, for all of my colleagues in the Future Vision, and for you, all of you in your future work. And our colleague now in Future Vision will continue with you, inshallah, according to the timetable of the symposium. Thank you for all again, and كل عام وانتم بخير إن شاء الله.
Can you hear me? Okay. طيب هنبتدي الحين بالمحاضرة آخر محاضرة حق الصباح. Good morning everyone, and we will start our session today. Yesterday in the afternoon we were talking about the diabetes emergency. شفنا كل الحالات اللي ممكن سببه مريض السكر أو ممكن المريض من خلالها يروح على قسم الطوارئ for treatment. تكلمنا عن الام اي وعن الستروك وعن الدي كي اي والهايبوغلاسيميا والكيتو اسيدوزس والى اخره. وكمان في قسم تكلمنا عن الدايت اللي هي very important in order to avoid the complication and to have a good lifestyle for the patient. الحين اليوم حنتكلم عن الفيزيكال اكسرسايزنج، لانه امبارحه صراحه في كثير من الاخوه المشاركين بالتعليقات طبعا طلبوا منا انه شو هي انواع الرياضات المسموحه، هل يا ترى مسموح نعمل الرياضه ولا لا؟ we need to do exercising or no, what type of exercise, and do we need to eat before or after exercising. هاي كثير من التعليقات اللي امبارح اجتنا، انه هل يا ترى اذا انا مريض سكر هل يا ترى I need to do exercising، وشو هي انواع الرياضات اللي لازم اعملها، وشو علاقه الاكل بالرياضه، هل يا ترى لازم اسوي اكل قبل الرياضه ولا بعد، or and what type of food. تكلمنا عن الفود امبارح. اليوم today we will be talking about the physical exercising. فإذا why do we need exercise؟ السؤال الأول والكل سأله، do we need exercising؟ We are a diabetes patient. We need to take a rest. We don't want to lose our energy. We shouldn't lose our blood sugar. Now, do we need exercising? The answer is yes, yes, yes. Why? Because first of all, by doing exercising, we will mobilizing of glucose from liver glycogen stores. We will mobilize of fats to spare blood glucose. We will synthesize of new glucose in the liver and blocking of glucose in these cells for sustaination of fat as a fuel. فإذا كثير مهم إنه to start the at least the people with diabetes, الناس اللي بيعانوا من أمراض السكر should ideally accumulate a minimum of 150 minutes aerobic exercise each week. فإذا أول معلومة بتقول إنه أنتم على القليلة يعني at least you should have around 150 minutes. يعني أنتم بالأسبوع لازم كيف ما كان يكون عندكم حوالي 2.5 ساعة رياضة بالأسبوع، مش باليوم ولا يوم بعد يوم per week. يعني إذا بنحسبهم it will be good. يعني كل يوم مثلا Sunday exercising for 1 hour, Monday off, Tuesday exercising for 1 hour, Wednesday off, Thursday مثلا تاخذوا half an hour. يعني من حوالي 2.5 ساعة 3 ساعات let's say it's a good. It will be good من 2.5 3 ساعات رياضة بالأسبوع، أو ممكن نعملها مش ضروري ساعة، ممكن نعملها 45، بس هو معدلها إنه المفروض 2.5. If you will do it by 45 minutes 45 minutes it will be يعني perfect time to يعني spread over at least 3 days of the week. يعني المفروض نحن نعمل مش 3 أيام. هلا في كثير ناس بيقولوا أوكي مثل على ايام المدرسه بنقول انا والله انا بما انه انا مطلوب مني اعمل هذا الشيء let's do it one time. No, it's a mistake because you will be tired, you will go for hypoglycemia and you might fall down. كثير مهم تعرفوا انا وقت بقول لكم 150 دقيقه او هيك يعني مش معناته انه انا فرض واجب زي ما بنقول انا بسويه الحين وخلص، لا، مفروض تتحرك على القليله 3 أيام بالأسبوع. يعني أنت بتقول أنا اليوم عندي بدي أعمل أحد 3 وجمعة مثلا، هيك يوم إيه يوم لا بتريح. فاذا بي كيرفول، ما نعمل لهم كلهم هودي هالوقت اللي قلنا لكم عنه اللي هو ساعتين، اللي هو ساعتين ونص يا 3 ساعات let's say، ما نعملهم as one shot، ما نعملهم on one day. we could do it يعني 3 أيام بالأسبوع، وكل أسبوع كل يوم ممكن نعمل على سايت 45 أو 50 دقيقة مش أكثر. لأنه مثل ما قلنا it will improve the glycemic control. طيب شو هي أنواع الرياضة اللي ممكن تعملوها؟ طبعا مش كل أنواع الرياضة بتناسب مريض السكر. اوكي، فاذا مش كل انواع الرياضات هي مناسبه لامراض السكر. الاكسرسايز اللي هن flexibility exercises are stretching and just to improve the motion of the muscle and joints. فاذا انواع stretching الايروبيك exercise cycling البايسيكل السويمينج الووكينج and the running الهايكينج because it will increase the cardiovascular endurance. تذكروا نحن مرضى السكر ما ناخده از مرض بس، بدنا ناخده مثل ما قلت لكم بنهايه الشغله نحن بنشتغل على قصه اللايف ستايل. اللايف ستايل اللي هي شغلتها to avoid the complication. تكلمنا امبارح عن المايوكارديال انفكشن complication، قديش القلب ممكن يعني يتأثر بموضوع السكر على الوقت الطويل for long term. For this reason you need to improve the cardiovascular endurance، متانة وصلابة القلب والدورة الدموية والى آخره. مشان هيك وهذا بيصير من خلال الاكسرسايزنج لايك وات، مثل ما حكي لنا سويمينج، هل صحيح اول 20 دقيقه للجسم يحرق الجلوكوز بالدم بعد يبدا هلا باجمالا حرق الدهون ببلش بعد النص ساعه. after half an hour you will start burning from your fat. اول فتره بتبلش تحرقي اللي هي اشياء المين الووتر ريتنشن. طيب فاذا نحن مثل ما قلنا هيدي الرياضات اللي هي رياضات الكارديو بنسميها. اذا انتم بتروحوا على الجيم حتى بتشوفوا انه في شيء مخصص هيدي الاشياء للكارديو، مشان هيدي شغلتها تحسن الكارديوفاسكولار انديورنس او الدوره الدمويه. مشان هيك هيدي جدا مهمه علشان القلب. هيدي بنسميها الايروبكس اكسرسايزنج. Anaerobic exercising such as weight training, functional training or sprinting increase short-term muscle strength. كمان بدك تعرفوا شغله انه قصه الانايروبكس لايك الويت تريننج شيل الاثقال صراحه to be fair and to be honest to you نحن ما كثير الى حد ما يعني ننصح بالاشياء الايروبكس اكثر من الانايروبكس، لانه الهدف منها مثل هي الانايروبكس مثل ما بنشوف انه الويت تريننج او الاثقال والحديد والى مش معنى الحديد الاثقال يعني البطولات العالميه لا، بس هي الهدف منها كمان يعني تجميل سبيشالي المسل. لان بتعرفوا الانسان مع السكر he's always looking pale، بيكون لون شاحب اول شغله. ثانيا بيكون في عنده body weakness اللي هي من اكثر علامات body weakness يعني it means كمان muscle weakness. مع الوقت وقت ما بيكون في good irrigation، وقت ما بيكون في good vascularization، هذا هالشيء كله بيأثر على الشكل الخارجي للجسم وبصير في نوع من الترهل عند الجسم، ترهل بالعضلات. مشان هيك وحده من الرياضه انه نحافظ على الايمج او على البادي تبعنا، انه نعمل some of the weight training. It's good بس كمان هي بتتطلب كثير من السعرات الحراريه باي ذا واي، وكمان بتتطلب كثير من المجهود، وكمان ما نعمل اشياء اكسترا يعني exercising that it might affect us. مشان هيك يعني always you prefer the aerobic exercising لانه it will be under your control وما كثير بتحط pressure on you. In addition على قصة الفاسكولاريزيشن والكاردياك اندورنس كمان الايروبكس exercise it will be involved on improve oxygen consumption by the body. انت بتعرفوا كمان عندنا مشكل بالاكسجينيشن. it will improve the oxygenation consumption. To obtain the best results, the aerobic exercising should be warming up period followed by involve a warming up period followed by at least 20 minutes of moderate or intensive exercise involving large muscle groups. فإذا يعني بنحمي الجسد وبنبلش بالاكسرسايزنج وبطريقة نشغل كل العضلات الجسم. For example, running a long distance at a moderate pace in aerobic exercise, but sprinting is not. Playing single tennis. وإلى آخره. فإذا مثل it will strengthen your muscle. It will enlarge the heart muscle to improve. كبر الشاشة بس. It will enlarge the heart muscle to improve the pumping efficiently and reduce the resting heart rate, known as aerobic conditioning. فإذا بتساعد عضلات القلب to enlarge the heart muscle and to improve the pumping efficiently. Toning muscle through the body, improve circulation, improve the total number of red blood cells in the body, and improve the mental health, which is very, very, very important. هيدي قصة المنتل هيلث كثير مهمة، والرياضة هي شغلة جدا مهمة على هالموضوع، لأنه بتعرفوا نحن أصلا الإنسان الطبيعي مش عقلكم مريض السكر هو already we are over stressed. كل يوم نحن especially us as healthcare practitioner we are يعني the stress is our bread بنقول، هذا خبزنا اليومي. نحن كثير we are under a big pressure. طيب إذا بنحكي عن مريض السكر اللي هو بيعرف إنه he's nowadays they know that it's a life illness and he need to do exercising sometimes not because he like to do it but because he's forced to do it. هو مش عم يعملها لأنه مبسوط كل يوم يمشي، بس لأنه يعني to avoid many complications. We need to educate our patient about the importance of the exercising on improving the mental health. كثير بيخفف من الإرهاق وكثير بيخفف من التعب وكثير بيخفف من الاكتئاب الرياضة. كلنا بنعرف من حالنا، أنا وقت بكون أيام بكون على الدوام يعني بكون تعبان وإلى آخره، بروح على البيت كثير over stressed. سبحان الله مجرد ما اطلع وبلش امشي وهيك بحس حالي خلص مثل شيء وانشال عن صدري، مثل شيء كثير زعجني وارتحت منه. كمان مريض السكر اللي بيعاني على فترة طويلة من الزمن، هذا كمان he needs to understand that the importance of the exercising. قديش هالشيء بيساعده على تخطي الحالة النفسية والجسدية، عدا عن الاشياء اللي تكلم عن الاشياء الميديكال اللي بتحسن الدورة الدموية والرياضة. فإذا it will at the result it will reduce the risk of health due to cardiovascular problems. كمان in addition the high impact aerobics activities that jogging or jumping can stimulate the bone growth and reduce the risk of osteoporosis on the woman. طيب كمان حكينا هذه فاذا نعطي هي الانايروبيك exercising. It's exercising, it's intense exercising رفع الاثقال والى اخره. It will reduce stress, yes, and it will increase the availability of fuel to the muscle. طيب شو هن كمان الافكت تبع هالاكسر؟ It will improve the body use of insulin. كل ما عملنا حركنا الدورة الموية كل ما جسمنا يستعمل الانسولين بطريقة احسن واسرع ومور افيشنت، لانه احسن ما يضل هذا الشيء بجسم الانسان وما يقدر يتحرك. burning excess body fat result in improving insulin sensitivity. انتم بتعرفوا شغله جدا مهمه كمان، بالاخص المرضى اللي بيكونوا دايابيتس تايب 2. شو تكلمنا عن الدايابيتس تايب 2؟ اذا بنرجع للاوليه، شو هي اكثر سبب؟ هي مش mainly it's not an autoimmune system problem. هي mainly there is caused by many reasons. One of the main reasons اللي هي الobesity او الاكسترا ويت. انت وقتها بتكوني عندك an extra weight in order to ليش بننصح المرضى الناس العاديين اللي بيكونوا عندهم وزن زائد؟ شو بننصحهم؟ النظام الصحي والغذائي والتمارين الرياضية. هيدي دائما بننصحها. يعني مريض، بتعرفي انتم حدا عندكم ولد مثلا اوفر ويت عامل البي ام، او مثلا بتروحوا عند الطبيب، والله بيقول لك انت في عندك 80 كي جي اكسترا، ولدك عمره 17 سنه او 18 او 20 سنه، لازم يكون وزنه 60، الحين وزنه 85 او وزنه 90 والى اخره. عنده هذا الشيء معرض يكون على الديابيتس تايب 2. منشان هيك نحن بننصح انه دائما اتباع النظام الصحي الغذائي والرياضه الصحيه، الرياضه اليوميه. For diabetes type 2 طبعا انت وقت you are a diabetes type 2 patient ننصح انه تعملي كثير من التمارين الرياضيه، عدا عن قصه القلب والى اخره، لانه it will burning the fat. بس بنفس الوقت ما في انا اطلب من المريض، ان مريض السكر، انه بما انك عم تمشي you can eat whatever. لا، هي it's a combination. It's a combination of we call it a lifestyle combination of food and combination of exercising. هنا عن قصة كمان it will improve the muscle strength and it will lower the BP because مثل ما حكينا قلنا هي لها كثير تأثير على cardiovascular system and helping to protect against heart and blood vessel disease by lowering cholesterol. طيب I have a question. انتم بتعرفوا يعني نحن كيف بيصير الفينومين او كيف بتصير الشغله انه مريض هالسكر بيوصل لمرحله انه يصير في عنده هذا الهارت بروبلم؟ مثل ما تكلمنا، لانه وقتها بيكون في عندي الكوروناري ارتري اللي هو بيغذي القلب، الهارت ماسل، اكثر شيء يكون افكت، لانه مع مريض السكر it's the main artery that is affected by the من خلال الكوليسترول. لو وقتها بيصير في بيسكر الشريان، وبذات مريض السكر، مرض السكر بيضعف وبيخليه very thin. مشان هيك بيكون كثير معرض باي لحظه يكون في عنده المشكل بالقلب. It will increase energy, reducing stress, promotion, relaxation والى. طيب نحن وقتها بيجي مريض السكر من اول فيزيت للطبيب بيقول له you need to have a ideal weight مثل اي انسان. اذا انا او انتم مثلا بنروح نعمل الحين البي ام اي وات ايفر، بنعرف انه نحن انا ماي هاي وزني مثلا طولي اعتبري 181، المفروض يكون وزني مثلا for example 75 or 70 or اعتبر. طيب كمان مريض السكر from the first visit كمان we need to الطبيب يحط له an ideal weight، بيقول له انت مفروض هذا الوزن تحافظ عليه، ونحن كل شيء ينعمل على اساس انه you should not gain an extra weight. طيب هل يا ترى اذا هالمريض حافظ على وزنه he should stop the exercising، اللي هو الهدف نحن بنقول اكسرسايز. انا ليش بروح على الجيم مثلا، او بقول انا بروح لانه انا طبيب حاطط لي او التغذيه او الكوتش قال لي والله انت اليوم عندك 10 كيلو you need to take it out you need to lose 10. طيب انا وصلت لمرحله خلصت على 10 كيلو، خلاص do I need to stop؟ مريض السكر انا do we need to stop exercising if you reach your goal for sure no, because the exercising is a lifetime commitment. هذا commitment التزام. فإذا الcommitment هي التفسيرها هي التزام. you need to, it's a lifestyle. برجع بقول لكم تذكروا انه هذا الشخص او هذا الانسان هذا انسان معرض على كثير من الكومبليكيشن وما في علاج له يعطى. يعني بعدنا هلا ما توصلنا انه خذ هذا العلاج واشفى من مرض السكر. نو. نحن من الانسولين والاكسرسايزنج والدايت كله هدفه avoid the complication and good lifestyle. مشان هيك you should not stop exercising regardless on your weight. You should you should continue doing the exercising as we said every day or day per day. يعني مثل ما حكينا على القليلة 3 أيام على القليلة 3 مرات بالأسبوع مثل ما تكلمنا يعني الصباح أو for 20 to 40 minutes. كمان هلا بتقولوا لانه كمان انا بخصوص الاكل بما انه انا I am willing to do exercising and diabetes patient. طيب انا شو بعمل بالاكل تبعي؟ امتى لازم اكسس؟ امتى لازم اكل؟ هل يا ترى باكل قبل التمارين؟ هل يا ترى باكل بعد التمارين؟ او what will be the recommendation؟ بالنسبه للnutrition and exercising, when exercising it become even more important to have a good diet to ensure that the body has the correct ratio of nutrient providing the good food. يعني أهم شيء أعرف إنه ما بيكفي أنا أعمل exercising وما انتبه على أكلي. ما هذا شيء غير كافي نهائيا. لا بده يكون it's a combination. زواج اثنيناتهم مع بعض. فإذا ما في أنا exercising بلا food ولا food بلا exercising. Liquids are ideal after exercising. نحن فإذا مش مسموح المريض يروح على مريض السكر يعمل exercising and هو جيعان يعني عنده جوع. He did not eat. هيدي شغلة جدا dangerous. مرض اصلا شعور الجوع عند المريض مش مسموح مريض السكر. مش هيك نحن كثير بنحبس قصه السناكس. نحن وقت بنعطي 3 وجبات وبنقول you have the right to have 2 snacks in between. نحن يعني هذا شيء واضح ومعلوم انه بناء على دراسات انه ممنوع السكر ممنوع يكون عنده شعور الجوع او ممنوع يقفل الوجبات او ما ياكل الوجبات. فاذا المريض ما مسموح انه يروح على يعمل اي تمارين ويكون عنده جيعان. لا لازم يكون اكل قبل الاكل بوقت ويروح هو ومرتاح ما عنده اي شعور بالجوع او بالعطش. شغله جدا مهمه. liquid are ideal after exercising. كمان السوائل كثير مهمه تتاخد بعد ما يعملوا الاكسرسايز. and there is several studies show low fat milk and chocolate milk are being effective recovery beverage because of ideal combination. انتم بتعرفوا الجسم نحن وقتها يعني ideally الانسان وقتها ببلش يعمل اكسرسايزنج اول فتره بالاخص اول 20-25 دقيقه هيدا الشخص هو ما بيفقد الفات. اول فتره بنبلش نفقد الاشياء الاملاح والووتر والى اخره. بعد النص ساعه او بال40 دقيقه الى الساعه بنبلش نفقد الدهون اللي هي الدهون بالجسم. طيب if you will compare a normal person to a diabetes patient. نحن شو عم نطلب من diabetes patient؟ نحن وقت عم نقول له المريض ده بيجي شيء 40 ساعه يعني بعد توا ما لحق يبلش يفقد من الفات بعده عم يفقد هالاشياء الووتر ريتنشن والاملاح والى اخره. فاذا انا لاحظت بحساباتي انه هذا المريض بعد 40 دقيقه من البلش رح يكون فقد جزء كبير من الووتر والاملاح والى اخره. مشان هيك انا I need to do something. بدي اعطيه شغله عشان يعوض له هالاشياء اللي خسرها. مشان هيك الشوكليت ميلك او اللو فات ميلك اتس ا جود كومبينيشن، لانه فيها من البروتين وفيها من الفيول. هيدي بتكون فيها كومبينيشن، فيها نسبه دهون قليله، فيها نسبه بروتين عاليه، وفيها البروتين اللي هي كثير مهمه مثل ما البروتين اللي هي بتحسس الانسان بشعور الشبع، بيكون شبعان بس هو ما بيكون عم ياخذ اشياء شوجر والى اخره. هذا اهميه البروتين. البروتين وقت بتاخده ليش بيطلب منا البروتين؟ انت بتاخده بتحس بالشعور يعني مثلا بتكون بتمرن، اذا بتفرط على الكارب والسكر هي بتصير تطلب اكثر، كل ما تاكل شوجر كل ما تطلب اكثر، لانه ما بيعطوك شعور بالشبع. يعني انا مثلا اذا بنزل بتمرن بالجيم او بروح اكسرسايزنج، بوصل بعدين بحط لي واحد كنافه بقول لك اوه بيرفكت، باكل وبعدين ممكن اكل شغله ضل اكل، لانه هيدا شغله يعني ما بتشبع منها. بينما البروتين وقت بتاخذ انت بتروح بتعمل اكسرسايز تاخذ لك مثلا بيف او تشيكن او وات ايفر بريست اللي بيكون بروتين، تاخذ البروتين انت خلص بطل عندك شعور الجوع. مشان هيك نحن مريض السكر ضروري هيدا الشعور ما يحسوا شعور الجوع، ولازم نعطيه اشياء مشان يعوض التعب تبعه. كمان في كثير من الاشياء او بتنسال انه هل يا ترى انا اذا مريض سكر وعندي ريتينوباثي، بتعرف اللي بيكون عنده مشاكل بالعين بيكون قصه ال الخوف، يعني بيقول انه انا ما بحب اعمل لانه عيني ممكن افقد عيني. بتعرفوا اللي بيكون عنده مشاكل بالعين ما بيحبذوا كثير قصة الرياضة، لأنه الرياضة هي بحد ذاتها انتنسيف، هي فيها كثير من المجهود، وبحد ذاته اوتوماتيكلي المريض بده يحس حاله انه يعني انا ما في احط مجهود او بريشر على عيني، بحس نوع من الخوف which is يعني مبررة طبعا، كل انسان هيك. طيب وقتها بيكون عندنا ريتينوباثي، مريض عنده ريتينوباثي، هل يا ترى ننصح what do you think if the patient has retinopathy ننصح بالرياضة؟ what do you think؟ لا، رياضة غير عنيفة. ثانك يو أخ أيمن. إذا نحن ما بنقول مثل ما قلت لكم ما بنقول كلمة إنه مش مسموح، لا يعمل المريض، بس طبعا من الرياضة أعتقد طبعا يعني الرياضة الغير عنيفة. يعني أنا وقت بقول لكم في عندنا تمارين الأيروبكس أنايروبكس، يعني عندنا قصة المشي وعندك السويمينج وعندنا كل شيء ما بتحط بريشر على العين وما بتكون انتنسيف او ما بتكون يعني ما فينا نروح نقول له للمريض ريتينوباثي اوكي انت اعمل الرياضه، بيقول لك والله انا بدي اروح اعمل كيك بوكسينج مثلا. كيك بوكسينج اللي هي ما فينا نقول لها لا طبعا، مريض السكر ما فينا نقول له عنده ريتينوباثي ما فينا نطلب له يعمل كيك بوكسينج او يعمل مصارعه حره، لا نحن نطلب منه يعمل اكسرسايزنج يكون هو مرتاح فيها، ما تكون تعمل اي يعني. فاذا اللي بيكون عندهم كمان، لانه في كثير من الاسئله بتجي وفي كثير من مرضى سكر الريتينو بالاخص مرضى اللي بيكون عندهم ريتينوباثي بيكون عندهم خوف من الرياضه، لانه بيقول لك انا ما بدي احط اي بريشر او ما بدي اذي عيني. لا we would advise you to do exercising but exercising بطريقه تكونوا مرتاحين وما تعملوا التمارين اللي المؤذيه، التمارين اللي بتحط يعني بتروح العين او بتاذي العين. طيب الاكسرسايزنج اند hypertension، المرضى السكر اللي بيكون لهم ضغط would you advise them to do exercise yes or no؟ فاذا المرضى نحن حكينا ريتينوباثي شرحت لكم عنه، المرضى اللي بيكون عندهم ضغط، امراض الشرايين، الضغط، ضغط القلب، بلاد بريشر، مرضى السكر، مش عم نحكي عن المرضى العادي، مريض سكري وعنده هاي بلاد بريشر، ننصح يعمل الرياضه ولا لا؟ نعم. who will say yes, who will say no. التمارين تحسن الضغط. Excellent. What else? Yes. تمنع التجلطات. Excellent. إذا كان ضغطه ممكن يعطي رياضة غير عنيفة. Excellent. تحسن المزاج. ممتازين. increase insulin sensitivity. هلا نحن عم نركز اخ فاصل على قصه تحسن الدوره الدمويه. مظبوط. تمارين المداومه عليها. اكسلنت. كل كلامكم مبسوط 100%. قد تكون جزء من تعديل انضباط الضغط. اكسلنت اخ عمار. ممتاز. طيب. تحسين المزاج طبعا. increase utilization of excellent. طيب الايديا هون بالنسبه للبلد بريشر مثل كل كلامكم مظبوط 100%. بتحسن الدورة الدموية وبتحسن الضغط وبتحسن والى اخره. بس في شغلة جدا مهمة. إذا اجاني مريض سكر وضغطه مش مظبوط، أنا ما بروح بقول له روح مال exercise، لا بقول له روح you need to control your blood pressure then later on do the exercise. وضحت؟ يعني أنا بيجيني مرض مثل ما شرحنا إنه الاكسرسايزنج جدا وكل كلامكم مظبوط، بس كلامكم مظبوط بحالة وحدة إذا كان البلاد بريشر under control. إذا ما كان البلد بريشر اندر كنترول هذا المريض ممكن يروح على اللي تكلمنا عنه امبارح، ممكن يروح على ستروك. تكلمنا عنه امبارح كثير. فإذا كثير مهمة. أنا الإكسرسايز جدا مهمة. اللي حكينا عن الريتينوباثي ما في أي مشكل يعمل الرياضة بس بشرط ما تعمل اكسرسايزنج يعني كيك بوكسينج والمصارعة الحرة. بالنسبه للضغط لا، ما بخليه يبلش يعمل بالاكسرسايزنج الا ما يكون البلد بريشر اندر كنترول، لانه اذا ما كان اندر كنترول هذا المريض ممكن يدفشه يعمل ستروك هو عم يمشي. لانه تخيلوا مريض مثلا عنده هاي بلد بريشر، هاي سيستوليك وهاي بلد بريشر، قول له يلا روح امشي 45 دقيقه ويبلش يركض والى اخره. لا ما حتى يعني بهالحاله لا، الرياضه مش عم نستعملها بالمكان الغلط. بطلب منه go to your cardiac doctor when your blood pressure is stabilized you can start walking. وطبعا مش اكسرسيس. المريض بيكون عنده blood pressure ما مطلب منه يكون عمال يعمل اكسرسيسات او الرياضه العنيفه. وضحت المعلومه؟ اي سؤال عن هذا الشغله؟ اكسلنت. شكرا. تسلموا جميعا. طيب كملنا. الاكسرسايزنج اند نيفروباثي. شو علاقه يا أخت فرحانة الله يخليكي، ممكن يكون مشكلة عندك بالصوت مش من عندنا، لأنه كل أنا عم بقدر أتواصل مع جميع المشتركين بشكل ممتاز. بقى لو سمحتي الله يخليكي ممكن يكون البروبلم من الديفايس تبعك. طيب في عنا الاكسرسايزنج اند نيفروباثي. شو له علاقة؟ would you advise your patient to do exercising if he has a nephropathy مشاكل بالكلى؟ هل يا ترى انتم تنصحوا المريض حسب رايكم مريض السكر لازم يعمل exercising؟ اذا مريض السكر مريض السكر اوكي على الكل، بس انه عنده نيفروباثي مشكل بالكلى، هل يا ترى ننصحه بالاكسرسايزنج؟ what do you think؟ تمارين خفيف. نحن كان عندنا ايفيدنس قديش اهميه السكر على البلد بريشر انه بيسحب، بس هون ما في عندنا يعني ما عندنا هيك just let me tell you that يعني كمان بمطرح من مطرح نحن واجباتنا انه نهون على المريض يعني، بس انه بمطرح من المطارح ما فينا نعطي هاي اكسبكتيشن. يعني بمعنى ثاني مريض البلاد بريشر بطلب منه يعني it's very easy انه يروح عند الطبيب ويركلج ضغطه ويمشي على تريتمنت معينه ودو اكسرسايز. مريض الريتينوباثي و اتس اوكي كمان، بس مريض النفروباثي جاست يعني to be fair and to tell the truth انه ببعض وقت المريض ننصح اذا في امكانيه يعمل رياضه لا، بس المريض وقت بيوصل لمرحله النفروباثي ديابيتس بيكون نفروباثي هايبرتنشن، هذا مريض صراحة يعني بصير الاوت كام ما بقى فينا نعمل كثير هاي الاكسبكتيشن، اللهم انه نساعده على قصته لانه بيحملش بيفوت موضوع الهيمودياليسيس والاند ستيج رينال ديسيش والسي ار ار تي والى اخره. مشان هيك نحن وقتك نوصل لمرحلة النفروباثي بنشيل قصة نطلب من المريض كثير اكسرسايزنج بتصير صعبة، يمكن ممكن نطلب بنقول له حسب ما انت بترتاح، بينما وقت بتكون المريض ببدايات المريض وعنده امراض الريتينوباثي والضغط at some point يعني we will push for the exercising، بس هون ما كثير we will not push we will advise وبنقول له حسب ما انت تكون مرتاح. وطبعا الرياضه اللي هي جدا 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 خفيفه، ممكن المشي هلا عم اختي اخت لطيفه، ممكن المشي البسيط العادي، بس ما بتقول له you need to work مثلا 45 minutes 3 days مثل ما طلبت من المرضى الريتينوباثي والبلاد بريشر والمرضى العاديين، لا. هذا الفرق اللي هون انا المريض بقول له حسب ما انت تكون مرتاح وما تتقيد بوقت اللي هو بس ما تتقيد بوقت ال 45 دقيقة. بقول له أنت إذا حسيت حالك مرتاح جاست ووك، وبس تحس حالك تعبان ارجع بأرضك ما تكمل، لأنه وقتها مصير مرحلة النفروباثي هي اللي عم جرب أوصلك إنه بتكون المرحلة صارت أشياء أدفانس غير ما تكون بعدنا بقصة المراحل اللي قبل. طيب شو هي أخت مرام الله يقدم لك الصحة والعافية، وعم تقولي إنه أنا مريضة. طيب هلا برجع بقول لك يعني يعني قصة هيك you need to see with your cardiac doctor. أنا مش مخول يعني أعطيك إشياء على إشياء قصة الضغط، لأنه هو طبيب القلب هو الأخبر بقصة يعني بقصة الضغط، لانه دائما بس انا وات اي كان تيل يو اهم شيء نعرف شو الاوريجين تبع البلاد بريشر، يعني هو ريليتد تو شو مشاكل، لانه الضغط بيكون له علاقه بيكون بسبب اسبابه يعني مش سبب واحد. اهم شيء وقت بيكون مريض بينطلب فحوصات من كل شيء، من ايكو وصور وفحوصات دم كلها تنعرف شو سبب الضغط ونشتغل على يعني نشتغل شو على السبب المعين اللي ودى انه يصير في بلاد بريشر، وعلى اساسه بينعطى هل يا ترى هي مشاكل بالقلب، هل يا ترى مشاكل بالكلى، هل يا ترى مشاكل ستريس، ما بعرف. بس دائما هو الطبيب القلب هو الكارديوفاسكولار هو اللي بي هيك. for this you need to go for a full investigation، فحوصات شامله وكامله عشان نعرف شو السبب قبل ما نقول انه شو الدواء والى اخره. والله يقدم الصحه للجميع ان شاء الله. طيب فاذا شو هي الباريرز فور اكسرسايزنج؟ يعني بيجي مريض انا بقول له طبعا اي ويل ادفايس للبيشنت بقول له لازم تمشي ولازم تعمل اكسرسايز ولازم، but sometimes في عندي باريرز ما ممكن ما في اتخطاها. المريض ما ممكن يسوي اكسرسايزنج نتيجه باريرز معينه او اشياء معينه، يعني المريض ما في يتخطاها. اللي هي اول شيء illness لدي طفل عمره 7 سنوات ووزنه لازم يزيد. طبعا يعني لازم تجي بالاخص اذا كان في عندكم مشاكل سكر بالعائله، يعني we have a family history of diabetes وعم يزيد وزنه بشكل اكثر من اللزوم، طبعا we need to لازم تشوفيه على endocrinologist. فإذا شو هي البارنس؟ illness and physical limitation، يعني مثلا like what؟ يعني مثلا في مريض عنده مشاكل برجله regardless، ما هو عنده مشاكل already regardless عن السكر، وايش مرض السكر؟ هالإلنس منعته يعمل exercising. This is one of the limitation. اوكي، يعني عنده امراض معينه تمنعه يمنع يعمل تمارين رياضيه، غير عدا عن مريض السكر اللي هو اجى مثل ما بتقولوا on the top. lack of time. lack of timing، قلة الوقت. وهون يعني I do not agree with this point. يعني بيجي مريض بيقول لك انا، او شخص بيقول لك والله انا ما عندي الوقت الكافي عشان نسوي تمارين. لا، we need to find the time. نحن بنقول your time it's a top priority. لا، المريض وقتها بيوصل لمرحله السكر والى اخره، يعني ما في هذا، لازم يلاقي التايم، لازم يحط التوب برايورتي. كل شيء زيارات وعلاقات اجتماعيه والى اخره هيدي بتصير سكندري. بالوقت المريض السكر لا، تايمينج اتس فيري امبورتنت. يعني ونحن هيدي السلايد جبناها بناء على statistics انعملت على آلاف المرضى اللي بيعانون من مرض السكر، وسألون إنه ليش أنت شو هي الأشياء اللي بتمنعكم تكونوا تعملوا رياضة. هيدي كانت البوينتس اللي أخذوها. طيب، lack of time مثل ما demand from family friends، بيقول لك والله أنا اليوم نظرا لمتطلبات العائلة ومتطلبات الأصدقاء والعمل أنا ما أقدر أسوي تمارين. هيدي ما ليست مبرر. الجوب ممكن نقدر نبررها، بس الفاميلي والفريندز غير مبررة. your health come first. مفروض مرضى السكر التمارين الرياضية اليومية مثل ما تكلمنا بدون أي انقطاع. inclement weather which is يعني كمان هذا شيء مش بيدنا ولا بيدكم. يعني إذا بنشوف اليوم مثلا مصلحة الأرصاد هنا محذرتنا بالسعودية بالرياض على موجة غبار صار لها 4 أيام، وهلا الحين عم بسمع إنه اللي عم يحذروا الوقت الحين إنه في موجة غبار قادمة. بقى بقى هذا شيء طبعا لا، مش رح يسمح لحد يعمل الرياضة، لا مرضى السكر ولا لغير مرضى السكر. هذا شيء كمان من الباريرز which is unpredictable, it's not on our hand. ما نقدر نسوي. بالعكس بننصح بهيك ظروف مناخية انه يلزموا البيوت ولا يعملوا اي رياضة. تمارين في البيت اذا في امكانية، ليش لا؟ اذا في امكانية انسان يعملها بالبيت يعني. بس طبعا انا واثق انه معظم المرضى رح يستغلوا قصة الوزر مشان ما يعملوا رياضة، بيقولوا تيحطوا الحجة بالطقس اليوم بالمناخ. واللاك اوف موتيفيشن اللي هي الحوافز، بيقول لك يعني هذا كمان شغله مثل ما قلت لكم this is not my personal opinion اللي حلمتها. هيدي statistics ودراسات اجريت على مرضى يعاني من مرض السكر، وهيك كان الجواب تبعا انه ليش، شو هي الاشياء اللي منعتهم يعني lack of motivation. بيقول لك والله انا يعني بقول الحمد لله انا اجاني هذا المرض، اوكي بس انا يعني خلص بعرف انه انا مش رح اشفى من هالمرض it's going to stay with me. خلص I'm not motivated. بطل عندي انا يعني نفسيا بطلت يعني بطلت عندي الحوافز اعمل رياضه، لانه انا بعرف حالي انه خلص هذا مريض ما رح اشفى منه. this is برجع بقول لكم البوينتس اون بيهايند، انه نحن بنقول خلص اذا الحمد لله واجتك هذا المرض خلص اوكي، مهم ما تخلي حالتك تتفاقم اكثر we should be motivated to do your exercising. You should be motivating to follow a proper food to avoid the complication. فإذا السمري very important to do especially مرضى diabetes just to improve the glycemia, to maintain your weight, to reduce the risk of cardiovascular disease and overall mortality, we need to do the exercising. ومثل ما تكلمنا الوقت شفناه يعني it's very important at least 150 minutes in a moderate intensity. ما طلبنا exercise يكونوا جدا يعني صعبين وبذات الوقت مش انه الموضوع تمشي يعني نطلع لا يعني تكون اشياء at least in between this one بالاخص يعني بالاخص مرضى التايبس 2 اللي عندهم اكسترا ويت الاكسرسايزنج جدا 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 مفيده مشان ما توصلوا نحن بنسميها في شغله بنسميها بري دايابيتس. البري دايابيتس هي بيكون اشياء انت مثل ما بيقولوا على باب البيت عندك بدك شيء يدفشك تصيري بالبيت. هيدي مريض السكر. البري دايابيتس المريض اللي بيكون عنده وزن زائد وعنده نسبه السكر والكوليسترول عالي هذا بنسميه مريض بري دايابيتس او مخزون السكر كثير عالي. هذا مريض باي لحظه خلص دخل للبيت دخل لجوا بطل فيه يطلع. فاذا والفلويد انتيك دائما يتاخذ قبل واثناء وبعد الاكسرسايزنج. اوكي any question. I wish you enjoyed the session. ان شاء الله تكونوا استفدتوا من المحاضره و if عندكم اي سؤال I am ready to answer your question before moving to the lunch break. شكرا يعطيكم الف عافيه جميعا. فإذا if there is no question now you can take your break. فإذا نعطيكم استراحة إن شاء الله للساعة 1 على الساعة 1 بنكون مع المحاضرة الأخيرة بعد الظهر قبل ما نكون بالبوستر برزنتيشن. فإذا you will have a break now. Break till 1 o'clock and at 1 o'clock إن شاء الله we will start again. Thank you. يعطيكم العافية. السلام عليكم. Good afternoon. طيب حنبتدي الحين بالمحاضرة الأخيرة إن شاء الله قبل ما يكون في عنا البوستر برزنتيشن. it might take يعني حجرب كون سريع شوي فيها لأنه ممكن يكون في محاضرة تانية إن شاء الله أجرب خلصكم إياها مشان نعطي كل المحاضرات اللي انحطت بالبرنامج. مثل ما شفتوا كان مؤتمر شامل وكل نواحي اللي لها علاقة بمرض السكر تطرقنا إليها وتكلمنا عليها بشكل كتير مسهب. يعني بقى المحاضرة الحين حنتكلم على كمان وحدة مثل ما لاحظتوا بالقسم الأخير من المحاضرات عم نحكي على قصة المانجمنت. خلص هالسكر مرض السكر وقع وصار في complication how to manage الكومبليكيشن. هلا من الوحدة اللي بتصير كتير وهي أكثر شغلة المرضى بيعانوا منها مرضى السكر. إذا بتشوفوا حسب رأيكم شو هي أكثر نسبة للأدميشن من وراء مرض السكر؟ يعني شو إذا رحتوا على مستشفى الحين وأخذتوا مثلا في 50 مريض سكر شو أكثر حالة related لمرض السكر موجودة بالمستشفى؟ اللي هي الديابيتس فوت. This is what we call diabetes. هي أكثر complication أكثر سبب للhospitalization نتيجة مرض السكر. لأنه أنتم بتعرفوا السكر it's a lifestyle. You will take the treatment at home الأنسولين والوقاية وإلى آخره. وما نفوت على المستشفى إلا إذا كان في شيء من الكومبليكيشن. مش كل مرضى السكر بيكون عندهم complication الهارت والرينال بس عدد لا بأس به. It's a book number. They have a diabetes foot. طيب just we will start our session with the statistics that over 4,400 patients with diabetes were seriously evaluated over 25 years. نحن أخذنا لأنه ليش؟ لأنه الديابيتس foot it will not come in age. ما معقول مريض يكون عنده مثلا مرض سكر اليوم وبعد شهر يا شهرين يا سنة he will end with diabetes foot unless there is something very special. But mainly one of the major complications بتصير اللي هي قصة الديابيتس foot اللي هي for a so long period of time. For this reason we conduct like studies over 4,400 patients من خلال اللي صار ما عندهم مرض سكر من 25 سنة. Neuropathy was defined as a decreased sensation in the feet and depressed or absent of the ankle reflex. ليش صار في عندهم diabetes foot؟ لأنه وحدة من النيوروباثي اللي بتصير عند المريض الكومبليكيشن بيصير فيه decreased sensation in the feet and depressed or absent of the ankle reflex. الإحساس بالقدم وبالأنكل بخف بشكل كتير منخفض. لاحظنا وقتها نحن أخذنا 4,400 patient over 25 years. لاحظنا نسبة 50% they end with a neuropathy which is it's not a small number. فإذا عملنا دراسة على 44 أو 4,400 مريض مرضى سكر over the last 25 years. We found that 50% of those patients end with neuropathy يعني مرضى سكر or diabetes. Food ulceration is most common cause of hospital admission for diabetes. فإذا مثل ما قلت لكم أكثر نسبة admission عند مرضى السكر هن مرضى السكر الذين يعانون من الفوت ulceration. It's expensive to treat, yes, and if it's not treated well, it might lead to amputation and need for chronic institutionalized care. فإذا diabetes foot هي من الأشياء كتير الكومبليكيشن اللي بتصير عند المرضى and this is one of the it's أكثر سبب للadmission. This is a major signs of or the major cause of admission to the hospital, and if it's expensive to treat it, and it's painful for the patient, and it might end with amputation and gangrene and amputation, and we need to patient he needs to be hospitalized. Why do you think a patient, why the high rate of neuropathy it will end with morbidity? Because there is a recurrent lower extremity infection and ulceration and subsequent amputation مشان هيك hospital mortality بتكون. طيب نحن how would you say that the patient he has a diabetes foot, or what are the stage of diabetes or diabetic foot? اوكي شو هي الستيج تبع هذا الموضوع؟ المريض مش فجأة بيصير في عنده diabetic foot. اوكي يعني مش فجأة المريض بيوعى بعد يوم او بعد شهر او هيك بيروح دغري على ستيج 4 فور اكزامبل. نحن مريض السكر بيقطع بمراحل، منشان هيك اتس فيري امبورتنت جاست تو هيك منشان هيك على طول بنطلب تشيك اب للمريض، وبنطلب انه على طول الزيارات الدوريه والطبيب يكشف عليه ويشوفه، وحتى اذا ما في امكانيه في كثير من المراكز المتخصصه او ممكن يجوا عندك على البيت just to avoid such complications. مشان هيك كيف يبلش نلاحظ عند المريض انه he has a good potential to have a diabetic foot. First one, if you will say there is 5 grade yet you need to take it in consideration. The first one is a grade 0. كيف لاحظته هون؟ شو الشيء لاحظتيه هون؟ انه المريض في احتمال عنده potential انه يكون في diabetes foot. فاذا شوفوا لي جريد 0 شو له علاقه هون الجريد 0 بالدايابيتس فوت، وشو الاحتماليه يصير في عند دايابيتس فوت and what did you notice in this picture؟ شو لاحظتوا على القدمين هون بالليفل بالجريد 0؟ what did you notice؟ what did you notice here؟ شو لاحظتوا بالجريد 0؟ ثانك يو اخت خلود. ممكن انه الجفاف يعني دراينس. ثانك يو اخ رمزي. فاذا مثل ما شفنا هون اللي لاحظته انه the feet are dry، في نوع من النشفان. شو يعني هذا dry؟ شو بيعني النشف؟ وقت بتشوفوا الفيت it's dry what this mean؟ شو بيخطر على بالكم اول شيء؟ جفاف. طيب شو معنى العرق؟ سهولة foot appear dry. Yes, what this mean؟ decrease blood supply. Thank you. Thank you. There is decrease on the blood supply. يعني البلد there is no good قلة التروية للدم. Thank you. فإذا there is no blood supply or there is blood supply in a very small quantity or there is no enough blood supply to the feet. فإذا ما في blood supply عم يوصل مشان هيك صار في هاللون الأبيض أو هالجفاف. مجرد ما تشوفوا عند المريض هيدي هيك this is we call it a grade 0. I can't say this is a diabetes foot, but this patient he has a great potential or a good potential for going for a diabetic foot. طيب الله يخليك اخ هادي كلك ذوق من لطفك. طيب بنشوف الجريد 1 هون. فاذا خلينا نشوف انه انتم اذا لاحظتوا اي شيء على هون ما تهملوا الموضوع اذا كان رجل المريض بهذه الطريقه. فاذا هذا المريض بلش يميل ناحيه الدايابيتس فوت we need to know to treat or to know what's going on. بالجريد 1 شو صار في عندنا هون؟ شو لاحظتوا بالجريد 1؟ What did you notice in the grade 1? احمرار المنطقة. Thank you أخت ريم. يعني لاحظتي مثل redness. Presence of inflammation. تقرحات. Excellent. Redness. أكثر شيء أنا لاحظت إنه swelling و redness. Thank you أخت سلوى. تورم وأحمرار. Excellent. فإذا this is what we notice here. صار في عندي أنا superficial ulcer involving the full skin but not underlying. بعد ما فت على التيشو أنا لاحظت إنه برجل المريض صار في عنده نوع من السويلينج ونوع من الإحمرار. هذا بيعني إنه there is kind of inflammation or there is something. فإذا بدي بلش هون بلشت احتمالات الديابيتس فوت it's more clear. إذا بنروح على الجريد 2 what did we notice? There is a deep ulcer. في ألسر غميقة شفتوا إذا بتلاحظوا هون على الصورة. ما بعرف إذا الصورة واضحة بالنسبة لكم، إذا قادرين تشوفوها بشكل كويس. إذا بنشوف هون بالجريد 2 بنشوف لاحظنا إنه في عندنا a deep ulcer تقرحات عميقة penetrating to the ligaments and muscle. وصلت على المصل على العضلات but no bone involvement or abscess formation. بس لحديت هلا بعد ما لاحظت انه هون ببلش فوت بقصه الجانجرين والى اخره. هون ببلش فوت بقصه الجانجرين والى اخره. وقتها بشوف انه there is no يعني deep. Stage 3 what did you notice? In the stage 3 what did you notice? شو لاحظتوا بستيج 3؟ اوكي فاذا شو لاحظنا هون؟ there is a deep ulcer with cellulitis or abscess. فاذا هون بالجريد 3 انا شو لاحظت؟ انه خلص شفتوا هذا السيلولايتس والابسس والديب ألسر وصار في عندي اوستيومالايتس. فاذا هون خلص صارت بمرحله الجانجرين جرجرينا. بقى 4 و 5 ما قدرنا حطينا صور بس مينلي بهاي المرحله خلص I need to go for amputation. بهاي المرحله اللي هنا خلص we needs to go for amputation. بطل فينا. فاذا هيدي مراحل شفتوا كيف بلشت الفوت ألسر من المرحله اللي فيها the skin is dry ناشف لمرحله اللي صار في عندي gangrene and I need to go for a deep amputation. خلص صار بدي اروح على amputation لانه هذه الشغله اللي حنشوف شو تاثيرها بحال ما رحنا على الامبوتيشن. You will see what will happen. ومثل ما شفتوا هيدي اتس بيكتشر كمان بتوضحكم الاشياء بعد اكثر واكثر قديش مدى تاثير المرض السكري الديابيتس فوت كيف المريض يعني بصير لاي مرحله. This is نتيجه النيوروباثي. كلير. وهيدي كمان صوره بتوضحكم اكثر. Look at the feet here. مثل ما شفتوا هون خلص. There is no way to survive unless we will go for intubation, amputation, sorry. طيب أنا كيف تعرف إنه yes for sure needs amputation now. طيب what are the signs of foot infection؟ أول شغلة we will have erythema, it's warmth, tenderness or swelling. The pus is coming out of an ulcer site and or sinus. يعني ببلش عندي erythema, tenderness, swelling وبلش لاحظ إنه there is pus coming out. Now, first of all, أنا how I'm going to evaluate the patient who has a potential of diabetes foot. نحن كيف how would you evaluate إنه كيف أنا بعرف إنه this patient he has a potential of diabetes foot. يعني هذا المريض أول شغلة on the patient evaluation we need to know by optimizing the glucose control. أول شغلة لازم أعرف إنه أنا مجرد ما أعمل كنترول على البلاد شوجر أنا خففت نسبة 50% احتمالات الفلوت بروبلمز. اوكي يعني لانه بتعرفوا حكينا عن الرول تبع الانسولين بشكل مسبق مش رح نرجع نعيد نفس التفصيل but for you to know الرول تبع مجرد ما انا اعمل optimizing or control the blood glucose انا خففت احتماليه الفوت problem by 50% 50%. على موضوع الفاسكولار دائما it's very important كل مريض بيكون عنده مريض السكر just to assess of the peripheral pulse for it's very important كمان يعني to assess the peripheral pulse and just to see if there is any potential. كمان from the orthopedic science side, always the orthopedic patient, he needs to be seen the patient just to see if there is any لأنه ulceration مثل ما تكلمنا إنه هي it's very well known إذا صار في أي contractures لأنه هي ما رح تبلش دغري عند المريض ulceration ممكن تبلش dryness بس المريض مش دغري بيروح على الالسريشن في كثير من العلامات ببلش المريض يحس فيها يعني تعطيكم مثل منه اول شغله بيكون مريض السكر فجاه يعني اذا بتطلعوا فيه بتشوفوا الرجل بنوع ابيض صارت هذا اللي بيكون قرب يفوت بمرحله الديابيتس وبتحسوا انه رجله it's mainly like a snow لون الابيض بعدين بيقول لكم I start to have like a contracture شو يعني contractures what do you mean by انه diabetes foot patient he will start feeling like a contracture فإذن he will start he will start مثل tension يعني ببطل اجه بتحس مثل على طول شاده بطل فيها هيدي الموبيليتي بطل فيها هيدي سهوله الحركه بيحس انه على طول بيجي مثل كيف انتم بصير فيكم شد بالعضل على طول عضله شارد مش عم في يعمل هيك كمان هذا اول شيء ببلش انتبهوا كمان هاي الشغله جدا وقت المريض ببلش يحس هذا الموضوع we need to be careful انه بلش الموضوع عنده بعدين ببلش تحسوا انه صار في عنده deformity and prominences يعني ببلش في عنده كمان deformity باصبعه بتحسوا ان اصبعه بلشوا صار في نوع من الديفورميتي اللي حشوا فيكم اياها in a picture كمان هودي من الاشياء just we need to know about it بعدنا بالpatient evaluation قبل ما اوصل انا how I'm going to evaluate my patient who has a good potential for diabetes foot X-ray very important why because the X-ray it will if there is any bony destruction it will show me if there is any bone destruction or potential or osteomyelitis and this شفته بالإكس-راي What is the difference between these two feet? شو لاحظتوا الفرق بين هيدا الرجلين؟ مثل ما شفتوا الديفورميشن، لانه هيدي this is the amputation here and this is deformation here. فاذا هون مثل ما شفتوا هيدي الحاله تبع المريض after صار في amputation، هون صار في already there is deformation. كمان السيتي سكان it's very important in visualization bony anatomy of for abscess. السيتي سكان بتبلش تفرجينا قبل ما يبلش يصير في باس لبرا، بنشوفين اذا كان في نوع من التقرحات او الابسس اللي جوا نتيجه الانفكشن، لانه بطل فيه هالتغذيه المعروفه. كمان how to avoid the foot care. First of all we need to avoid the smoking. دائما نحن يعني بالحالات الطبيعيه عند الناس الطبيعيين بنقول لهم we should avoid smoking, do not smoke because it will affect your organs. What about the patient اللي هن يعني مرضى السكر مع التدخين؟ It's very dangerous. Walking barefoot, the use of heating pads or hot water bottles كمان ما بخليه كتير يقرب على الاشياء السخنه، لانه اوريدي بطل صار في عنده احساس برجله، ممكن يتعرض على البيرنينج، يصير في عنده تشوهات، يصير في عنده حريق او بيرن نتيجه يعني لانه ما راح يحس بالاشياء، ممكن يحط رجله بمكان كثير 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 سخن ويصير في عنده بيرنينج. and stepping ودائما وقت بده مثلا ياخذ شاور او وات ايفر لازم يشيك على الحراره، لانه ممكن يحط على مي سخنه كثير وهو ما يعرف انه هو سمبلي بطل عنده السنسيشن. منشان هيك يعني لازم يشيك على المي قبل ما يستعملها، ما يستعمل مطرح يكون كثير كثير سخن يا كثير كثير مسقع، تكون يعني in between لانه he lose sensation. كمان من الاشياء اللي كمان لازم كثير ننتبه لها how to cut the nails عند قص الاظافر عند مريض السكر. It should be on the shape of the toe and filled to remove sharp edge. On a daily basis we need to inspect our feet. المريض اللي بيكون عنده سكر بالاخص المرضى اللي بيكونوا bedridden patient. bedridden يعني هن المرضى المنومين، المرضى اللي already يعني ما عندهم كثير حركه. how the مرضى on a daily basis we need to check the foot. لازم كل يوم نشيك على رجل للمريض on a daily basis، لانه at any time we might notice something. By checking we need to be looking between and underneath the tooth and a pressure area of skin breaks, blisters, swelling or redness. كمان بنشوف بين الاصابع تنشوف اذا كان في عندنا اي نوع من البلستر تقرحات، swelling تورم او في redness، يعني بدنا نشوف الاصبع، بدنا نشوف بين الاصابع اذا لاحظنا اذا في نوع من التقرحات او في نوع من التورم او نوع من السويلنج او breaks we need to report this. يعني مشان هيك عم اقول لكم on a daily basis we need to check the foot of the patient. The patient may need to use a mirror or if vision is impaired have someone else perform the examination. كمان مثل ما قلت لكم هلا المريض ما في يطلع على كل رجله، اوقات بحاجه لمرآة مرايه عشان يشوف الفيت تبعه، عشان يشوف رجله. مشان هيك اذا كانت هالشيء مش متوفر او المريض ما يقدر يعمل good inspection we will train him how to use الميرور. اذا كان كمان ما يقدر مشان هيك نحن على طول بنطلب انه في كثير من مرضى السكر هن دائما بيروحوا على مراكز متخصصه او اوقات بيتعاقدوا مع في ناس بنسميهم ديابيتس تيم او ديابيتس نيرسز، بيجوا لعنده على البيت اذا مش كل يوم مره مرتين او 3 مرات بالاسبوع، وبيعملوا الفوت اكزامينيشن وبيشوفوا اذا لاحظوا اي signs and symptoms او علامه من هول العلامات اللي كنت انا already عم بتكلم فيهم تم just to report it. كمان وقت بده يلبس الشوز تبعه المريض ما لازم يكون من النوع بدها تكون كتير تايت، يعني ما لازم تكون كتير ضيقه، ما لازم، لانه مشان ما تعمل بريشر على القدم وعلى الاصابع. at the same times القطن نوع الجوارب اللي يعني نوعية الجوارب ما لازم تكون بدها تكون من القطن. ليه؟ ليش نوعية الجوارب بدها تكون من القطن ما لازم تكون من النايلون؟ For what reason? What is the reason? طبعا لأنه القطن يمتص الرطوبة ويمتص التعرق، بينما القطن هداك ممكن يعمل حساسية عليه وممكن يعني يعمل حساسية. مشان هيك فإذا أهم شيء وقت بده يلبس الشوز يلبسها ما تكون كتير ضيقة على الرجل، تكون واسعة بطريقة هو يكون مرتاح، مش واسعة كتير كمان مشان ما يتعرض الإطاحة بالأرض، يعني لا تكون يعني fair enough، بتكون يقدر يمشي فيها بطريقة كويسة، طريقة مريحة. وأهم شيء الجوارب تكون ما تكون نايلون، تكون نوع القطن، لأن القطن بيمتص التعرق وإلى آخره. كمان it should be changed and every، ما بقول إنه الجوارب خلص لبستها since it's a cotton no problem، لا on a daily basis it should be changed. كمان we need to wash the feet on a daily basis with water. mild swab should be used and the feet should dry gently. كمان ما بخليها تضل رطبة، بجرب نشفها. بعدين after بحط اشياء من المرطبات، كريم او لوشن بنحطها just to be apply. فاذا general recommendation اللي بنحكي عنها بهذا الموضوع هي انه الديابيتس foot it should be examined على طول. at least يعني المريض اللي بيكون عنده diabetes foot at least he needs to go to the hospital one time per year، على القليل لازم يروح مرة بالسنة مشان يعمل general check up، لأنه يعني مثل ما قلنا هيدي من أكثر الكومبليكيشن وأسوأ اللي ممكن المريض يوصل لها، لأنه you could imagine that the patient he will end with gangrene and amputation. It's يعني هيدي كتير شغلة المريض بيتأثر فيها. هودي اوريدي تكلمنا عنهم بس بدي. فإذا مثل ما قلنا السموكينج تريتمنت. Now we tried everything، مثل ما قلنا ممكن تكون احنا جربنا كل شيء عشان المريض يعني ما يصير في عنده diabetes for a reason. Now how we could treat a patient with diabetes foot. يعني جربت كل شيء وكل الاشياء الوقائيه اللي تكلمت عنها but for a reason، يعني patient and with diabetic foot. Now how are we going to manage the proper management? First it will start with a proper education. Already we talk about it many times. فإذا أول شيء بنبلش proper management it will start with a proper education. هون بيقول لي انه للاسف فحص الاقدام ما يطبق في مركز سكر اللي يشتكي المريض. anyway مثل ما قلت لك at least it should be one time per year to examine your foot. لازم تنعمل على القليل مرة بالسنة لمرضى السكر. how to prep. فإذا أهم شيء شوف أنا على structure skin changes peripheral arterial assessment، بنشوف التمبريتشر وسكين تشينجز ونيوروباثي اسسمنت. ناو اهم شيء فاذا في عندي كذا شغله اعرف. اول شيء بالانسبكشن بدي اشوف من خلال النظر شو لازم، مثل ما قلت اذا في اي بلستر، اذا في اي تشينجينج بالمورفولوجي، اذا في شيء كيف هو وضع النيلز والى اخره. بالبالبيشن pedal pulse and temperature and footwear very important. طيب شو هي الكومبليكيشن؟ انا مضطر شهل كثير، انا بعرف في كمان يعني صراحه هو مواضيع المؤتمر جدا جدا كبيره، بس انا مضطر اخلص الكونتكست، مشان هيك بدي اجرب خلص له بعد محاضره، بدي اجرب شهل بهذا الموضوع اكثر واكثر مشان لحق اعطيكم المحاضره الاخيره قبل التنتين. شو هي الكومبليكيشن اوف diabetes فوت بروبلم؟ اول شغله وقت مريض بيصير في عنده فوت بروبلم he's at high risk of skin and bone infection. رح يصير في عنده التهابات بالانفكشن بالسكين، رح يصير في damage بالنيرف and the blood vessel damage and the among immune system problem, and he will be always at high risk of infection. بصير معرض كثير للالتهابات. ممكن يكون المريض فإذا he will end with abscess. Abscess, he might have abscess. Sometimes infection eats the bones or tissues and create a pocket of pus called the abscess. فإذا هالinfection لأنه بطل في good irrigation, good blood flow، هذا المريض بصير معرض كتير، يصير في عنده شو؟ بصير المريض معرض كتير إنه يصير في عنده infection. مشان هيك infection not treated it might lead to abscess. وهون المريض ببلش يقرب، يعني ببلش من عند simple infection. Infection not treated بتودي يصير في عنده abscess. Abscess not treated it will lead to the gangrene اللي هي مثل ما الجرجرينة عند المريض اللي هلا حدا من الأخوة كان عم يسألني عنها، إنه هل يا ترى السكر هي اللي بتسبب؟ طبعا هي المسبب الأول والرئيسي للجانجرين هن مرض السكر. الجانجرين فإذا diabetes affect the blood vessels that supply your finger and toes. When the blood flow is cut off خلص بطل يوصل الدم، the tissue will die. مشان هيك treatment we need to remove this area who die because of the blood supply. وقت بيصير في عندي أنا gangrene automatically I need to go for بيصير في عندي deformities. Nerve damage can weaken the muscle in your feet and lead to problem like many problem, and at the end I might end with amputation. بينتهي المطاف بالموضوع إنه المريض he will go for amputation أو بتر القدم, which is يعني this is the end treatment or the last treatment for the diabetes. Now إذا المريض بساعتها how the treatment is going to be by debridement أو وقت بنضطر نفوت المريض على غرف العمليات just for the debridement of the necrotic tissues. For the ulcer healing بنضطر نعمل له dressing. بتعرفوا المريض بيصير المريض يجي يضطر على المستشفى بنضطر نعمل له دريسنج، لانه بدل ما عملنا الديبرايدمنت نظفنا بنضطر نعمل دريسنج تنخلي، لانه وقت بنعمل الديبرايدمنت بتصير الاوبن اريا اوكي بصير هاي ريسك اوف انفكشن و it's a good place for the bacteria and to be there. مش هيك بضطر انا اعمل دريسنج للمريض وخليها تضل على طول مسكره. كمان one of the treatment it's the skin graft and it's one of the treatment that we might go for it. ال HPO hyperbaric oxygen therapy كمان هاي من التريتمنت اللي بتعطي سبلاي اكسجين بشكل كتير عالي للأورجانز، وفي كتير من المرضى صراحة استفادوا على هذا التريتمنت. we have organized or we have many centers for the HPO in the kingdom and outside of the kingdom, and this is one يعني مثل ما قلنا هي إيش من الأشياء اللي treatment that it was very well known over the last year اللي هي الهايبرباريك اوكسجين ثيرابي. بيشوفوا المريض على غرفه كثير فيها ضغط الاكسجين بشكل كثير عالي وبينعطى الاكسجين سبلاي مشان رينوفيشن اوف ذا تيشو. اوكي any question before انا يعني كان بعد في اتوسع اكثر بس بعد في محاضره بدي احكي عن الكيتس بالمدرسه كيف نتصرف مع الكيس اللي بيكون عنده diabetes. فاذا if you have your kids has diabetes and he's going to school what should be done because بعد عندي هالنقطه لازم اتكرر عليها. Do you have any question about this diabetes food? Any question? الجزء الأخير اللي this is very important topics you will try to finalize it within 20 minutes إن شاء الله and وهو موضوع جدا موضوع ذات حساسية وأهمية لأنه أنتم بتعرفوا ومثل ما تكلمنا بالأيام الأولى أنه الديابيتس it might affect the young people الأطفال بعمر معين they might be witness a diabetes وهودي الأطفال الفرق أنه الأدلت they could manage themselves أنت وقتها adult and unfortunately you are a diabetes patient you could manage yourself at home at work يعني يكون عندك مرض سكر وانت عم تشتغل حياة طبيعية ومثل ما تكلمنا بالاول انه في كثير ناس بيضلوا كل حياتهم بمرض السكر and they are fine ما في مشكلة بينما الموضوع عند الاطفال يعني بيختلف لانه الاطفال قدامهم مشوار عمر كثير كبير وفي مراحل بيقطعوا فيها وهيدي مراحل اللي بالاخص مراحل الدراسه اللي ممكن تاثر هالموضوع عليهم نفسيا وجسديا منشان هيك وصعب يعملوا كنترول. شكرا يا اخت نوره كمان الاطفال ما فين يعملوا كنترول. ثانك يو فيري فاليد بوينت. منشان هيك نحن بدنا نشوف I am going to يعني raise a few points انه بيسالوها. هل يا ترى the first question should I tell the school that my child has diabetes يعني انت you have a patient your son or your daughter she is 7 or 8 years old she is diabetes. السؤال الأول should I tell هل يا ترى حسب رأيكم would you advise إنه المدرسة تبعه they need to know about it yes or no. فإذا ضروري جدا excellent yes we need to tell the school we should not be يعني ما لازم ان احنا نخبي هذا الموضوع بالعكس لانه مثل ما تفضلت وتكلمتوا انه الولد ما في يعمل لو adult he could control it بيعمل كنترول على الموضوع. اذا عادل بعمر 17 18 سنه he could control himself ما في مشكله بيعرف انه هذا الاكل ممنوع وبيعرف انه هذا الانسولين بده يتاخذ بس المدرسه لا. بس الولد بعمر 7 8 سنوات المدرسه لازم تعرف لكثير من الاسباب. اول شيء تتشوف تتعرف انه he's a diabetes and he need special care الشغله الثانيه لانه انتم بتعرفوا ممكن يكون في وقت تيراقبوا المريض، لانه بتعرفوا الدايابيتس there is complication. ممكن المريض هذا يعني ما فيك تعتمدي انت مثلا على ولد 7 8 سنوات بأخذ جرعه الانسولين. he might forget it, he might lie on you، بيكذب عليك بيقول لك انا اوكي اخذتها، بيكون ما اخذها، وهيدي بتصير. وممكن يكون ما اخذها بطريقه كويسه، ممكن يكون اخذها اكسترا دوز، ممكن ما اخذها نهائيا. منشان هيك اول شغله المدرسه بتعرف انه شو هي بساعتها بتعمل فولو للمريض، بتقول له this is the insulin time. كمان بيكون في احتياجات خاصه، لانه مريض السكر he will be advised انه انت باي لحظه ممكن في عندك هايبوغليسيميا. بالحالات الطبيعيه اذا الولد بيقول له الاستاذ بالصف والله انا طالع على بالي اكل كنزي، شو بيقول له؟ بيقول له بيكون عليها كثير طف. بس مريض السكر بيقول له I need to take candies now, he need to give it to him. هيدا الديفرنس، مش بس من الناحيه النفسيه، من الناحيه العمليه. مشان لانه حياه الولد اللي عنده السكر بتختلف عن الحياه الولد العادي، لانه في عنده متطلبات واحتياجات اثناء الدراسه ده المفروض نأمنها. قصة الدواء المفروض يتاخد على الوقت، وقصة الاشياء الاحتياجات خلال الخروج. ممكن اوقات يضيق خله، يقشط معه السكري، بحاجه لسكر he need to take it. مشان هيك هودي الاشياء المدرسه مجبوره تامنهم للمريض. اذا المدرسه ما كانت عارفه بهذا الموضوع how they will manage the patient. اذا هيدي النقطه وضحت. Now who will manage my child diabetes in school؟ طيب أنا عندي ولد يعاني من السكر، مين مسؤول عنه بالمدرسة؟ What do you think؟ who will manage that child at the school؟ للأسف ما في متخصص بالمدارس. المرشد الطلابي لازم تمريض، مثل ما تفضلت الأخت إيمان، أنا مع فكرتك 100%. لازم يكون بكل مدرسة مفروض يكون في ممرضة شغلتها تهتم بكل الأولاد عامة، وبالأخص بالأطفال with special needs اللي عندهم احتياجات خاصة مثل مرضى السكري. يعني بتعرف هالممرضة عندها أسامي أنا مستشفى مدرسة فيها مثلا 500 تلميذ، بعرف أنا إنه في عندي أنا 10 مرضى هن مرضى سكر ويحتاجون رعاية خاصة. أنا بيكون عندي أساميهم، أنا بعرف إنه اليوم على الساعة 11 مفروض الكل ينعطى الإنسولين. I might call them to the nursing office، وأنا بعطيهم الإنسولين على الساعة 11 وبشيك معاهم على الأكل. ما في أترك، ما في يعني المسج أنا ما أقدر أترك هذا الموضوع بيد الأطفال. أخذ الجرعات والأكل لازم يكون في حدا أخصائي بكل مدرسة هو اللي يهتم. حتى ما في اتركوا الموضوع الأساتذة، لأنه في كثير بيقولوا أوكي أنا ببلغ الأستاذ. لا، ما نقدر نبلغ الأستاذ، لأنه الأستاذ هو عنده كذا كوميتمنت. ممكن يكون في عنده 10 أولاد يا 12 ولد بالمدرسة ممكن ينسى، ممكن ينشغل، بترك الولد ما يجوز. مشان هيك نحن هذا الموضوع مفروض يكون فيه أخصائي بكل مدرسة، أخصائي صحة تمريض بالأخص، هو شغلته يهتم بهذا الموضوع. شكرا. شو بتقلنا الأخت أحود هنا؟ شوفوا تعليقاتها جدا مثمرة. شو بتقلي؟ إنه بتقلنا نحن نشتغل بمركز سكري وتجينا كثير حالات أطفال لا يستخدموا الأنسولين في المدرسة، يكون مستحي، وبعضهم ما يعرفون وبيخافوا بحقوا أنفسهم. ممتازة، أنا بشكر كثير على تعليقك، لأنه أخت سوري يمكن الاسم ما يكون واضح بالنسبة لي، يعني أنت اختصرت المحاضرة كلها. هذا اللي عم نحكي، ما في اتكل على الاطفال. اخت عهود عسيري شكرا لك. فاذا ما في اتكل على الاطفال لانه ما يعرفون ولا يقدرون وممكن يتعرضوا للتنمر المفروض الاخ ايمن. فاذا هذه كلياتها مشان هيك اسباب ما لازم انا اتكل على رح يجوا كثير، رح يكون ضغط نفسي اكثر وقت الولد بنبعته من المدرسه على مركز صحي لانه صار في عنده مشكل بالسكر. What should the school do to manage my child diabetes؟ مثل ما قلنا بده يكون في مركز مخصص بالمدرسة، ناس أخصائيين، غرف مخصصة، ونشيك عليهم on a daily basis. كمان هلا انت كمان في شغله جدا مهمه لازم تعرفوها كاهل، انه وقت بتبعتوا الولد اللي عنده سكر على وقت بيقول اللي عنده سكر على المدرسه، في اشياء لازم كمان نعرف. اول شغله you need to have your child medicine. لازم الولد كل يوم يكون في لستة بالادويه اللي بياخذها، لانه طبعا مريض السكر ممكن يكون في كمان في مرضى في ميديكيشن معينين غير بياخذهم. مشان هيك بده يكون في عندها ليست اوف ميديكيشن بيكون متفق عليهم. انتبهوا شو عم لكم، شغله جدا مهمه. ما بقول انا انه انا الولد عنده هودي الخمسه ميديكيشن ببعته معهم وخلص without communication with the مع المدرسه. ليه؟ لانه هذا اذا انت بتقولي للمدرسه والله انا الولدي عنده 5 ميديكيشن بياخذهم او عنده ميديكيشن بياخذهم، لو سمحت اعطوه اياهم، هذا اتس نوت انف. ليه؟ لانه ممكن هذا الولد ياخذ 2 3 من الميديكيشن ويكبهم. ممكن ياخذ 2 3 من الميديكيشن ويعطيني ولد غير ويقول اوكي هودي الميديكيشن اللي معي اياها من البيت. ما وي كانت تراست. مشان هيك مفروض يكون في اجتماع بين الاهل والمدرسه، بيقولوا انه انا هيدي لسه الادويه تبع ولدي انكلودينج الانسولين في عنده 5 ميديكيشن غير، وهول الميديكيشن لازم يتاخذوا على هذا الوقت. ساعتها كل يوم وقتها بيروح الولد على المدرسه بياخذوا هالميديكيشن، الممرضه بتشيك على اسامي الميديكيشن وعلى الوقت وبتعطيها اياهم باليد. مش مسموح نحن نعطي الميديكيشن للولد نقول له تيك ات. It's forbidden, it's not allowed. هذا شغله، هذا خطأ مميت. بس بيكون عندي انا بالمدرسه اسامي بالادويه اللي المتاخده اللي لازم تتاخد وبنعطيهم اون تايم وبنشوفهم، والممرضه هي اللي بتعطيهم مش الولد. كمان your child meals and snack تكلمنا عنها امبارح عن الدايت. كمان ما في انا اليوم في مثلا يعني اتركوا الولد يروح مثلا على الكافيتيريا يشتري الاكل، لانه بوجود الاهل، انتبهوا بوجود الاهل رح يعملوا كنترول على الولد على الاكيد. بالمدرسه مش رح فيني يعملوا كنترول 100%، لانه الولد رح يستحلي اصبع شوكولاته، رح يستحلي اشياء من الكافيتيريا ممكن تضر فيه. مشان هيك لازم يكون في تشايلدز ميلز اند سناك يتفق عليها بين الاهل والمدرسه انه هودي الاكل اللي الولد المفروض ياخذهم، واوت اوف ذس بوكس don't give anything. هلا اللهم في بعض الاوقات بتعرفوا يعني الاولاد بالمدارس بيكون في يعني ممكن بيرزي ولد معين يضطر قطعه كيك مغينه، واوكي ممكن يعني هيدي نغض النظر عنها، بالمقابل نسحب من السناكس تبعه. هيدي اشياء يعني لابد منها، ما بدنا تاثر على نفسيه الولد، بس انه مش كل يوم ولا بنفس نفس الكميه. فاذا بنعتمد على المأكولات اللي انبعثوا، لانه المأكولات بالمدرسه هي اتس ريدي فور يعني هيلثي تشايلد، مش لولد يكون عنده سكر. checking your child blood sugar level كمان شغله جدا مهمه لازم اعرفها، انه كيف انا لازم شيك على ال blood sugar level on a daily basis بالمدرسه. مش بتكل انه خلص اجى الولد على المدرسه and blood sugar is okay خلص. كمان بالمدرسه on a daily basis I need to check everything. لازم كمان شيك على السكر. انتبه على كمان الاساتذه، يعني لانه بتعرفوا الاساتذه هن منهم بالقطاع الصحي. يعني الاساتذه هو بيعنى باشياء يعني ما لها علاقه بالقطاع. كمان انا اذا بالبيت في لاحظ اذا صار في انخفاض يا علو بالسكر عند الولد، بس بالمدرسه الممرضه ما فيها تكون بكل الصفوف طبعا، تتدخل وقت الحالات الطارئه وقت الميديكيشن، بس هالولد اللي بيكون جالس مع الاستاذ بالصف لازم حتى ينعطى education للاساتذه. we need to educate our teacher how to notice the primary signs and symptoms of the high or low blood sugar. الاساتذه لازم كمان يكونوا عندهم يعني معلومات، ولازم نثقفهم ونعلمهم كيفيه ملاحظه علو وهبوط السكر عند الولد، لانه ممكن الولد يكون يعمل هايبوغلاسيميا يعني الاستاذ هو ما يلاحظ ليه او ما يعطي اهتمام بالموضوع سمبلي لانه ما يعرف، مشان هيك كمان الاديوكيشن للاساتذه هي شغله جدا we need to educate them. It's very very important. كمان لازم يكون في على طول نوع من الكونتاكت، الهوت لاين بنسميه بين المدرسه والبيت، لانه بتعرفوا الولد هو بيكون بالمدرسه anything it might happen، واذا لا سمح الله اضطرينا ننقل الولد على المستشفى الاهل المفروض يكونوا يعني fully aware about this. مشان هيك يعني مشان هيك اني هيدا بسميه الهوت لاين، انه باي وقت الاهل لازم يعرفوا، والمدرسه لازم تعرف انه اي شيء بيصير مع الولد مفروض يكلموا الاهل باللحظه ذاتها. كمان انتم بتعرفوا نحن في بالكوريكولوم موجوده انه ساعات الرياضه، حصص الرياضه موجود. طيب انا كمان في شغله تكلمنا عنها هون، شغله سلاحظوا الرياضه ضروريه جدا، بس كمان انتم بتعرفوا مش كل الرياضات it might be applicable يعني لولد السكري. يعني انتم بتعرفوا اوقات بالمدارس، انا بعرف من بنتي مثلا بتقول لي بابا اليوم في عنا، او ولدي بيقول لي اليوم بابا نحن اليوم في عنا بالمدرسه مسابقه الركض او العدي الركض، اللي بيطلع الاول حيطلع له جائزه. طيب كمان من هالناحيه الولد اللي بيكون عنده السكر انا ما في فوته بهيك مسابقات تتطلب كثير من المجهود، لانه يعني he might fall down، يعني ممكن هذا الشيء ويأثر على نفسيته حتى. مشان هيك بجرب انا اعملوا انفولمنت باكتيفيتيز ما تعرضوا كثير لهبوط السكر والتعب والارهاق. هودي اشياء جدا شفتوا قديش ضوينا على قصص بالمدارس يمكن انتم ما بتفكروا فيها، بس بعد هالسيشن اكيد رح تعطوا انتباه لكل هودي المواضيع بالمدارس، لانه ما فينا نسلم الولد المدرسي كده. مش خطير، مش مشكله المدرسه، نحن هون مش عم نقول انه المشكله بالمدارس يا المشكله بالاهل، لا، بروبلم كلنا مسؤولين عنه وكلنا لازم نشتغل مع بعضنا just to have a healthy kids. لو سمحتم حدا فات معي على الاونلاين انتبهوا لانه بعدني بالمحاضره. Please put yourself in mute. فإذا هيدي اشياء كثير يعني كمان مثل ما قلنا كمان الشغله الاخر شغله بتخرج علي قصه الكونفيدنشاليتي. نحن مثل ما قلتوا الاطفال ممكن يكون في عندنا اطفال ذوي الاحتياجات مريض السكر، انا مش مسموح يعني لا سمح الله ولد صار في عنده اي مشكل هبوط بالسكر او صار اي عارض سكري ما مفروض هذا الموضوع ينحكى على صعيد المدرسه، بس الاستاذ اللي بيكون الصف والاداره والاهل. منشان هيك يعني شغله جدا مهمه قصه الكونفيدنشاليتي ما يعني ينحكى باسم الولد كثير بالمدرسه، لانه الولد رح يرجع على المدرسه ورح يصيروا الاولاد بتعرفوا الاطفال ما في كنترول. نحن عم نحكي مع كايند اوف بوبوليشن ما هن يعني سبحان الله هن اطفال ما فين يعملوا كنترول، رح يقولوا اف شوف هذا زميلنا امبارح صار عنده عارض سكر وانتقل على المستشفى او الاساتذه. منشان هيك نحن كمان الموضوع هون جدا مهم انه ما نخلي موضوع يتداول. it should be super confidential. واخر شيء بنتمنى الصحه للمجتمع وبنتمنى الصحه لاطفالنا ولمجتمعنا ولكم جميعا ان شاء الله. وبشكركم على الاصغاء لهي المحاضره. وإذا أي شيء I am ready to answer your question before moving to the يعني poster presentation. Do you have any question? أي سؤال بتحبوا تسألوني إياه؟ اوكي فاذا thank you for your attendance. والحين رح نكون مع حدا من يعني جروب من الاخوه حيعطونا few poster presentation، وهي بتكون المحطه الاخيره من المؤتمر. اوكي، نحن بنشكر حضوركم جميعا. And now remaining with the poster presentation that we could start it now. اوكي الاخت التعبير if you are ready you can start. تفضلي اخت تعبير اذا جاهزه.
Pfizer. We have two examples here, Pfizer and Moderna. Viral vectors use modified harmless to carry genetic instruction for making an immune response against coronavirus. At the end, some types of study, as for other medicines, timeline shortened. Pooling expertise, studies in large number of people, expected benefits at time of initial approval, demonstrated reduction in COVID-19 disease, some uncertainties for like example, long-term protection and community transmission, use of face mask, hand hygiene, physical distance remain important, high regulatory standard for quality, safety, and efficiency. That's it. I hope you're enjoying the presentation.
شكرا دكتور، يعطيك ألف عافية.
الله يعافيك.
كده بنكون خلصنا جميع فعاليات المؤتمر. Thank you for your attendance. نشكر حضوركم جميعا، وإن شاء الله تكونوا يعني استفدتوا وأخذتوا معلومات جديدة أو شكرا لحضوركم ويعطيكم ألف عافية. تحياتي لكم. Thank you.